recognize our sponsors for today's program, including RWJ Barnabas Health, the Matthew J. Morahan III Health Assessment Center for Athletes, and JAG1 Physical Therapy. I also want to take a moment to acknowledge our corporate partners, as we are the official healthcare provider for the New Jersey Devils, Rutgers University, Seton Hall University, Princeton University, Monmouth University, the Somerset Patriots, and the Jersey Shore Blue Claws. We're also an official corporate partner for the Athletic Trainers Society of New Jersey. So without further ado, I just want to hit some boring housekeeping items for all of you. This program does offer 4.5 CME and CEU credits for our physicians and our athletic trainers that have joined us today. I think you guys always miss this message, but I promise you, you will get your credit. Take a look at your emails in the next 7 to 10 days. We will send instructions on how to get that, I promise you. So just keep a lookout for that, and we'll make sure your credit is given. We also have opportunities for question and answer. We're going to doing a round robin today. Each presenter is going to do a 12 to 15 minute presentation, leaving about 5 minutes for questions. If you'd like to ask our panelists questions as they present, please just fire questions into the Q&A chat function, either at the top or bottom of your screen, and make sure that you address those questions to all panelists, not just the host, so that whoever's presenting can answer them promptly. All right, so we're going to get right to it. We are super excited to have Coach Greg Schiano on today, our Division I Rutgers football coach, who has kindly joined us on a game day. So thank you, Coach. I'm going to have Dr. Jason Krzysztofiak formally introduce him. So I will introduce Dr. K. Dr. K is both my colleague and my medical director. I have the privilege of working with him day in and day out. He's a wonderful guy. He's sports medicine fellowship trained and board certified in primary care sports medicine. He's assistant team physician for Rutgers athletics and head team physician for Rutgers football. He's also the medical director of sports medicine at Cooperman Barnabas Medical Center, as well as the medical director for the Morahan Center for Athletes here. He's former team physician for Sky Blue Professional Women's Soccer, and he's also assistant clinical professor with Rutgers RWJ Med School. Dr. K, the floor is yours.
Thank you, Diana, for the introduction, and thank you for everyone who's on this Friday morning. Really excited for a great game with Rutgers football against Nebraska tonight, so it's getting the day off started very well. I have a really unique privilege of introducing Coach Greg Schiano, who I work with pretty much on a daily basis. There is no such thing as an off season in football, especially at the Division I Big Ten level. So that's a 365 7 pretty much day operation, even leap year as well. So Coach Greg Schiano, so a couple really good facts. I think if you're a sports fan in New Jersey, he doesn't need an introduction, but there's a couple unique facts I just wanted to bring up. So Coach Schiano is the winningest coach in Rutgers football history, which is awesome, especially with growing up. I went to Rutgers, and I'm proud alumni of Rutgers and very proud to be a part of the Rutgers family. He has sent close to 100 players to the NFL throughout his career. Rutgers was #1 in academics in 2010, and it's hard not to note that our bowl trip to the Gator Bowl in 2021 was based on academics as well as the hard work the football team led up during to that time. In 2006, he was the unanimous college football coach of the year. And a really interesting fact, Coach Schiano has never changed his cell phone number like forever, because he wants to have all the thousands of players that he's coached have access to him 24/7 if they need him. So the time that he does coaching does not just stop at that if the athlete is not playing football for Coach Schiano anymore. It's a lifelong relationship, and that's what I see on a day-to-day basis. I'm not going to share his number today, although people might be questioned it. I'll just say it's 555-CHOP. You can try that number and see if it works out. But on a personal note, I have the highest level of respect for Coach Schiano. It's such a privilege to be a part of the Rutgers football family. It's in medicine, we sign up for lifelong medicine no matter what field you're in. And I feel like that's how I enter into the health center every day. It's every day I learn something new from Coach Schiano, and I apply that to medicine. And so far, it's been working out really, really well. So it's not just about developing elite athletes. It's about developing great young men that are going to go on to do great things either on or off the field. So without further ado, Coach Yano, I really appreciate you taking your time on a game day to be with us this morning.
Well, thank you, Dr. K. Very nice of you to say those things. I'd like to thank everybody that's on the call here for having me on and give me the opportunity to speak. We at Rutgers are blessed. We have the most comprehensive and literally the best sports medicine program in America. And I know people can say that, but I've been in the National Football League as a head coach. I've been at other major universities, and I can say that with great confidence. And I think one of the big reasons of any organization being successful, I think the biggest reason is leadership. And under Dr. K's leadership, I think our sports medicine has grown immensely, even in the short 2.5 years that we've been back at Rutgers. I just a couple things that I applaud the way that Dr. K does his job. Number one, he works really well with Josh Burchard. He and Josh are like a team, and they get things done for our players, for our coaches. And why is it so important, right? And you're dealing with athletes. I don't care what level it is, but certainly at this level is very intense. And these athletes have so much invested in their athletic and academic career. Well, when you play a sport like football, but really any sport, there's going to be injuries. There's going to be situations, everything from the common cold to major surgeries. And when you have a leader like Dr. K, he leads as I said, the most comprehensive sports medicine team, I believe, in the country. So everything from our trainers, who do an unbelievable job on a day-to-day basis with our athletes, our physical therapist. We have gone so far as to put a position in place called the Director of Integrated High Performance. And this is a guy, Tim Mahan, does that job for us. And Doc and he work very closely. And Doc and our head trainer work very closely. And we say very closely, like day to day, in not only treating the athletes together, but meeting constantly. And then they meet with me every single day and tell me where we are. I think it's so important that a coach and their sports medicine team are on the same page. It's not the coach's decision what a player should do or not do. That's a medical team's decision. And I think when you have a coach who respects the medical team, and especially the leadership of the medical team, that's when you have something really productive. And that's the way it is, at Rutgers. And again, I think leadership is everything in any organization. I don't care if it's a family, a football team, a business, it doesn't matter, a medical practice. And Dr. K's leadership is what has served us through probably the most trying medical time in our country's history, right? With getting through the COVID-19 pandemic with a football team, 130 players, 100 and something staff members. And the injuries didn't stop and the surgeries didn't stop, but then you had this whole additional thing where every player on the team, and literally Doc and I, and this is the kind of dedication that Doc would show and that our medical team would show. We'd be on the phone at midnight. We'd be back on the phone at 5, 6 in the morning. This guy's tested positive. We need to get these people moved into quarantine. And I think everybody dealt with it, but I couldn't believe that anybody dealt with it better than our medical team did. And when I talk about leadership, I think it really centers around our culture. That's how I look at it. It's 35 years of doing this. And taking all the things from all the people that I've worked with and for, and had the opportunity to put together kind of what we call our culture. And our culture is very simple. It's 3 things: family, trust, and shop. And family stands for forget about me, I love you. And we believe that love is not a feeling, but love is an action. And that action is sacrifice. And I cannot think of anybody who epitomizes family more than Dr. K. The way that he and our medical team sacrifice for our athletes, they win our athletes over one by one because of that commitment, that way that they spend time and explain everything, the way that they administer the treatments, the way that when kids are going through a major decision like a major surgery, they not only tell them all the pluses, minuses, pros and cons, but they're not, one of the things that I think is so necessary in leadership is is the absence of big ego. Right? And Doc, in our medical team, we have people that we use in our local medical team, and we also have people that we use all over the country to do surgeries. And Doc is right in the hub. He and Anthony Misuraka, our head trainer, Dave McCune, our director of training, is so important that they work together, that they organize the entire plan, and then let the student athlete and their family choose what they think is best. And I'd be remiss if I didn't thank Diana for all her help with getting our players, especially during COVID. What a craziness that was. But all the things that she makes happen for Dr. K so we can do the things we do in Rutgers football. Just an immense thank you. But family is number one, and Doc lives that. And I think our whole training staff, our organization lives that, sacrificing for one another. The second part is trust. And we have our own definition of trust. Trust is two parts. Number one, 100% honesty. And number two, do what you're supposed to do when you're supposed to do it. Well, if anybody lives that, that's Doc, because he lets me have it right between the eyes. Sometimes I need to hear it, and he lets me have it, whether it's my own health, whether it's our team's health. He's very good about it, but he's very stern about it as well. He'll let you know what you need to do. And this isn't guesswork, buddy, so listen up. Right? And I get it. Sometimes I push back, but the thing that you need in a team physician, in my opinion, is someone that is very collaborative, someone who works as a member of the team. But when it comes to medical decisions, they draw the line in the sand and say, that's what we're doing. Because coaches and athletes can be very persuasive. Coaches and athletes can be very hard-headed. And that's what makes them good coaches and athletes. But they need that medical professional to set the line in the sand, and Doc does that. So the honesty that he provides, right, and then doing what he's supposed to do when he's supposed to do it. So what does that mean? When he tells a kid something, I'll be here at this time, or we're going to do this, he follows through with it. And I think our whole medical team does that. And to me, when you tell them the truth and you do what you say you're going to do, every day that trust builds. And that trust is the most important thing that I can, as a coach, want between my medical team and our student athletes. Because when their trust is there, then you can make great gains. You can recover more quickly. You can do things that, kids are afraid of, right? This is something that Doc, he and his people know is the best thing for the student athlete, but it might not feel so good, or it might be something that's going to delay his recovery, but in the long term, make it much, much more beneficial. And the way that he talks to them with truth, honesty, straight, this is it. And then he does what he says he's going to do. That builds the trust. So when you have an unselfish leader who tells the truth and does what he says he's going to do, that builds an incredible trust and a feeling amongst the athletes and coaches that we know this guy is the guy that we got to listen to. And that's critical in any sports medicine situation. And then the last thing is CHOP. And we have our own definition for CHOP. CHOP's the mental and physical toughness it takes to stay focused on that spot on the tree when you keep hitting it over and over and over and over again. And, if you've ever chopped down a tree, you're going to hit that knot in the tree, and it's going to take a while, right? It's going to spit that axe back at you, and nothing happened on that swing. Yet you keep doing it. Eventually the tree falls. And that, I can't tell you how many times that was the case, and has been the case, and is the case on a daily basis. What Doc and his team do for our football team. And again, I'll keep bringing back up COVID, but I mean, amazing the level of dedication. And we call it the thing that distracts you from looking at that spot on the tree. We call them bombs. There's bombs going off in the distance, and you cannot allow it to distract you where you look up, because then you swing the axe, and at best you miss the spot on the tree, and it doesn't get any closer to falling. But at worst, you chop your wrist, your foot, your finger, you chop something off. And you can't let the bombs distract you. And I can tell you, I've never been involved in anything in my coaching career, 35 years, like we did 130 athletes through COVID. I mean, and all the way, the greatest testament I can give you is when we went to the Gator Bowl in the second outbreak of COVID, right? That was something, it was not a very good decision by the leader here. I made a decision that we would take the bowl bid with 8 days notice in the middle of I guess it was the Omicron version of COVID. And every single thing we did was umpteen times harder than it normally is. We couldn't get a plane to go down to Florida. We had to get 2 different planes because all the pilots and all the flight crews were coming down with COVID. And we were having players go down with COVID like daily. And Doc would come to me and say, okay, we got to test this yet. All right, he's positive. He's down. And the job that he and his staff did, standing tall, presenting the confidence, we got this. Our players that were healthy went out and played that game. And although I say I wish I probably should have reconsidered, it's one of the things, even though we didn't win the game, one of the things I'm most proud of, because our organization stepped up in a way that I've never seen a group of people step up to organize a trip in 8 days, to take 100 or 250 people to Florida and play in a bowl game against a ranked team, the champions of the ACC West. To do that is amazing. And Dr. Krzysztofiak was such a huge part of that. So where does the sports medicine team mesh with the coaching staff and the playing team? Oh, I think if you're really good, it's every single area. There's a mesh, there's a communication. And I think what Doc does the best job of, and our entire medical staff do, is they're right involved in everything we do. They're in team meetings. Now, they can't be at every team meeting, obviously, but they're there. The players see them. They see them up at the dining hall. They see them eating with us, hanging out with us. And now that, again, that trust builds, because at this level, especially, these guys, a lot of these guys, it's the NFL. It's been their goal since childhood. And when an injury comes up, that jeopardizes their chance to go to the NFL. And I think Doc and our medical team do an incredible job of keeping that in mind, but never, ever sacrificing what's best for the athlete. So I started this by saying we're blessed to have the most comprehensive and best sports medicine team in the country, and I believe that. So I know that all of you who are much brighter than I are going to get an incredible meeting here today. And I know if Doc's leading it, that it'll be off the charts. So again, thank you for listening to me, a football coach. But I think what sports medicine and the integration between coaching and sports medicine at Rutgers is the best. And it's something that I'm very, very proud of and grateful that we have Dr. Krzysztofiak leading the way. Have a great meeting, guys. We appreciate you.
Thank you, Coach. Thank you.
Thanks, Coach. Much appreciated. All right, take care. So we're gonna jump right into Dr. Krzysztofiak's talk on acute concussion, but while he's queuing up his slides, I have to say that CHOP message goes a really long way, even in the office here at RWJBH. I actually bought Dr. Krzysztofiak a cutting board for Christmas with a message that we were going to chop in 2022. So it's definitely something we try to live by, even with our daily sports medicine. So hopefully you guys got a little take away from that this morning. All right, Dr. K, you can go for it and jump right in here.
Great. I just want to just verify that you can see my slides on the home page there. Oh, Diane, can you see my slides?
Yes, all set.
Perfect. Well, again, really, just again, privileged and blessed that we had, Coach Yano on as a keynote speaker this morning, especially on a game day. I'm actually at the team hotel, so I please forgive me for the background, but this is we planned to have this talk for a very long time ago. So I picked concussion as the first topic for upper extremities about a year ago. So it has nothing to do with the recent events, in the National Football League or the news, but I think it's a really important topic to cover. And what I'm going to be focused on today is concussion recovery, exercise as medicine, because as a part of concussion recovery, we use with our concussion center exercise as medicine as a tool for faster and safer recovery. And we're just going to present on that this morning. And any questions, please put them in the chat. So just going to be just trying to advance my slides here. I have no disclosures to make. Just overview, going to be talking about physiological readiness, concussion and exercise, evaluation of exercise tolerance and exercise prescription. And of course, there'll be a Q&A as well. So some quick facts. So the CDC estimates around 1.6 to 3.8 million sport and recreation related concussions each year in the United States, which is a phenomenal number when you look at everyone doing activities that put them at risk for a concussion or just daily activities. An athlete who sustains a concussion is about 4 to 6 times more likely to sustain another concussion. So we see that a lot. We see definitely people with multiple concussions. Most children and adolescents recover within 2 to 4 weeks after a sport-related concussion. After that time frame, you get into the post-concussion phase. So acute concussion evaluation. So kind of just a thought for the audience. You know, there's a concern for a concussion, and you're about to do an evaluation, no matter what level medical provider you are. You know, what the question always comes up. You know, what do you check first? And you know, by far, C-spine. And during that initial evaluations, you really want to clear that C-spine. Obviously, if there's other distracting injuries or other things that are happening acutely, you have to triage that appropriately. But for someone who's just coming off the sideline, like, hey, I just got my bell rung, you know, you really need to make sure that that C-spine is covered before you're moving on to the further evaluation. So red flags, what to look for initially in a concussion: neck pain, midline tenderness, any type of double vision that's persistent, weakness, tingling, burning sensation in the arms or legs, increasing or severe worst headache of your life, any type of seizure activity or convulsions, a loss of consciousness is concerning. And we're not talking about a breathe for a few seconds. We're talking about for longer than a few seconds. Someone who appears completely normal and then all of a sudden has a deteriorating conscious state, concerning. Significant nauseousness and followed by vomiting that just keeps on occurring, and someone who becomes really agitated and combative, and you know, someone who's really not acting like themselves. So if you see these red flags at your initial phase of your concussion evaluation, it's a really good idea to get that person to a local emergency medical facility for consideration of neuroimaging. There's criteria, depending if you're a child or an adult, that the emergency department uses to guide that. But red flags, I definitely do not sit on red flags that unless things are changing. Red flags initially that rapidly go away, then you can have a medical decision making. But if they're staying and they're getting worse, definitely you want to get more help for that person. Some common symptoms, not going to review the list, but you know, when we're looking at it, there's a lot of overlap between concussion and other aspects. So when you're doing your concussion evaluation, you want to use all the tools that you have available to you and keep these common symptoms in mind: pressure on the head, blurred vision, being emotional, sad, not feeling right, difficulty with concentrating, not remembering, sensitivity to light and sound, feeling like you're in a fog. But again, there's overlap between other injuries, but just keep in mind these common symptoms as you're going through your evaluation. Now, concussion assessment, we usually typically do on the sideline, typically starts with the head and neck. As mentioned, many of you would do a SCAT that goes through your Glasgow Coma Scale, your Madox, or cognitive screen, etc. From a physical exam, we're looking at cranial nerves, cerebellar sensation, strength, deep tendon reflexes. Getting into more concussion specific, balance error scoring system, your best testing, your VOMS screen, and if you have access to do King-Devic, Buffalo Concussion Treadmill Test, and Impact. As a general rule, some of the newer research is pointing more towards VOMS and your symptom score as being the most useful for concussion diagnosis. And looking at tools and objective measures, it seems like the King-Devic outperforms some of the other computer-based tests more in the acute setting. So, for example, if I'm looking to diagnose someone with concussion, I'm heavily looking at symptom score, which I'm getting from the SCAT-5. I'm heavily looking at my vestibular ocular motor exam, and I'm looking at King-Devic, and I'm most certainly using a Buffalo Concussion Treadmill test. And we're going to talk a lot about that moving forward. Impact, still popular amongst a lot of institutions and programs. I'm finding it to be less and less useful. However, if someone has an impact at baseline, that's something we still follow because that is a baseline tool that we can still look at. So overall, when you look at everything that we're doing for the assessment, Essentially, during the concussion assessment, we're basically testing the whole area of your brain and your cerebellum and your brainstem. So we're looking at vision, your occipital lobe. We're looking at balance, your cerebellum. We're making sure the person does not have any type of breathing issues or issues with swallowing, your brainstem. Temporal lobe, we're looking at memory. Frontal lobe, problem solving, reasoning. Parietal lobe, knowing left from right. So during that assessment, we're basically testing the whole entire brain and brainstem during our assessment. Now, acute management, you have someone that you're concerned to have a concussion, suspicion is high. Definitely the right answer is removal from play or the circumstance. Complete cognitive and physical rest, pretty standard initial acute management. And then really about planning what's your next move. What are you doing for further clinical evaluation? The concern is high for a concussion, but maybe they don't have a concussion. What is going to be your follow-up plan to follow through with that diagnosis or ruling out a concussion? And what management are you doing? So sport-related concussion, that is typically a mild traumatic brain injury. Main thing, exercise intolerance is usually a really significant effect of what you would expect from a sport-related concussion. Yes, there's cognitive issues as well, but as you're looking at someone with a concussion, immediately that stands out is the inability to exercise to a level of predictive fitness. And on the sideline, if I'm ruling out a concussion versus other things such as a contact headache, before I can clear that student athlete, I have them do a series of aerobic activities to make sure that I'm not eliciting symptoms. Because if I'm eliciting symptoms with aerobic activity, I'm considering that person to have an acute exercise intolerance. And if that's occurring after a concern for a concussion, it's most likely going to be related to a concussion. So a lot of the people with concussions who don't even know they have concussions, they come and see us and say, I didn't really think I had a concussion, but I went for a run and I just couldn't do it. And we use that as an objective indicator of ongoing physiological dysfunction after a sport-related concussion. So rest is best was the recommendations for a very, very long time. That was based on animal research and consensus agreements. That was the past. Now it was really just focused on trying to prevent further injury, which is still the right answer with regards to contact, right? We want to prevent second impact syndrome. Although it's rare, it does happen. So we want to prevent that from happening. But this is referring to pretty much all physical rest. I'm not talking about just keeping away from contact. Newer evidence does not support strict rest beyond 2 days. And Berlin released a statement not too long ago in the last few years that closely monitored active rehabilitation programs involving controlled subsymptom threshold, submaximal exercise has been shown to be safe and may be benefit in facilitating recovery. So the rest is best is no longer best anymore. Newer evidence does not support it beyond 2 days. And that's pretty much where we're going to be focused on the rest of the presentation. So looking at exercise intolerance, exercise can exacerbate symptoms after a concussion. So return of an exercise tolerance, I use as a primary determinant of physiological readiness for sport return. So as you're diagnosing someone with concussion, you're maybe using the Buffalo Concussion Treadmill test to diagnose as a part of your workup because they're having exercise intolerance. But then after they're fully recovered and you're about to start a return to play, you may use that same test as a challenge, as an exercise challenge to see if they're ready to start a return to play. There's been a lot of different research and talk about different types of mechanisms around it. It seems like the one that really has been standing out the most is autonomic nervous dysregulation and impaired control of cerebral blood flow and reduced cardiac stroke volume. Aerobic training actually has been shown to have a beneficial effect on your autonomic nervous system regulation, cerebral blood flow regulation, cardiovascular physiology, as well as brain neuroplasticity. So as you can see, if after you have a concussion, if you have this exercise intolerance that's stemming from of an effect on the autonomic nervous system, but then aerobic training has been shown to have a benefit on your autonomic nervous system, that actually is a very elegant, that's a fit. That, okay, well, if this is the possible problem and aerobic training can help that problem, why not do it? So when we look at the physiology of sport-related concussion and the effect on exercise, we see that there appears to be an altered function of the autonomic nervous system and control of cerebral blood flow. So when you have this autonomic nervous system dysregulation, these changes that could occur in the autonomic centers within the brain or the brainstem can affect things such as your arterial baroreceptors around the heart and your central autonomic nervous system that can lead to this functionality issue that can cause you to have worsening symptoms after you have a concussion. Also, for someone who's been resting for a long period of time and then all of a sudden increases their activity, that metabolic demand can also cause there to be some effect on the ANS as well. So what some of the research has shown is that the autonomic nervous system obviously controls cerebral blood flow as a response to exercise. And in one study looking at female collegiate athletes, they found them to have a low sensitivity to pressure of CO2 with post-concussion syndrome. And because cerebral blood flow is proportional to the pressure of CO2, that elevation raised cerebral blood flow disproportionately to exercise intensity, causing them to have symptoms. So that in that study, it was basically saying like, okay, well, we have the person with post-concussion syndrome who is having these symptoms of autonomic instability, and now they're having all these symptoms of exercise intolerance, and they found it directly related to PCO2 and how that's related to cerebral blood flow. Since subthreshold aerobic exercise increases CO2 sensitivity to normal, that normalization of your pressure of CO2 has improved exercise ventilation, cerebral blood flow, and exercise tolerance. So when we look at that, when we see that there's CO2 sensors that are located in the brainstem, which could also sometimes be affected during a sport-related concussion, and that's near the autonomic control center for cardiopulmonary function, you can see that there could be a relationship to what's happening to the athlete who's having, these post-concussion symptoms. And when we look at aerobic exercise at a level of not causing there to be a worsening of symptom, it appears to regulate and normalize cerebral blood flow back to normal. So if you're looking at someone with a concussion and they're having symptoms, one of the possibilities is that there's abnormal cerebral blood flow that's related to all these physiological factors. And we're trying to come up with ways to re-regulate, reset the body and the mind back to a normal state so you're not getting these exertional symptoms. So that's where the Buffalo Concussion Treadmill test comes in. I'm not going to go through the nitty-gritty and here, but just know that it is used to prescribe an individualized sub-symptom threshold aerobic exercise program. And typically, symptom exacerbation is an increase in 3 points or more from a pre-exercise visual analog scale. So basically, the person either after 48 hours after a concussion, we're putting them on the Buffalo Concussion Treadmill test, and we're trying to figure out at what level does that person's symptoms exacerbate. And then we're getting a heart rate that's occurring at. So we know that if we're planning an aerobic recovery plan, we're going to stay away from numbers that are higher, because if you get higher into that symptom threat area, we're going to cause worsening symptoms. There's a bike test, just to be aware. I'm not going to go through the slide, but just so you're aware of it, there is a Buffalo Concussion bike test. And we typically do that for people who cannot go on a treadmill, whether that's significant vestibular ocular issues where they can't stand to kind of go back and forth running on a treadmill, or even as simply if someone just shows up to the office and they wore flip-flops and they can't go on a treadmill. But looking at the Buffalo Concussion Treadmill test and diagnosis, you can see on the slide here that it can be used in a lot of different ways. So initially, we use it as a way of seeing what their heart rate is and trying to come up with an aerobic recovery plan. But you can also use it for other things, such as if you have someone with a concussion and you're trying to get them to exert and get symptoms on the Buffalo Concussion Treadmill test, but they're not getting any symptoms whatsoever with exertion, but they're having symptoms at rest. Then you may, looking at the right side of the screen, you may want to look at other issues related to concussion or an alternate diagnosis, such as just a pure cervicogenic issue or someone with vestibular ocular dysfunction that may or may not be related to a concussion. So you can use the BCTT to kind of hone in on if they're having symptom exacerbation with exercise or not. Conversely, on the other side, if you have someone who's gone through a concussion, basically, post-concussion care, and they're having no symptoms, they're back to their baseline health, cognitively they're back. If there's an athlete in school, they're back to school. You can use the Buffalo Concussion Treadmill Test to determine physiological recovery before you start a return to play as well. Mostly what we're using it for is an exercise prescription, because we believe, based on all the research, that the aerobic recovery is really critical to resetting some of these factors that are causing the individual to have exertional intolerance. So when we use the Buffalo Concussion Treadmill Test, we are getting a submaximal symptom exacerbation threshold based on that Buffalo Concussion Treadmill Test, and then we're prescribing active recovery based on that, which is typically an exercise program for about 20 minutes a day at a dose of about 80 to 90% of that threshold heart rate before the symptoms would exacerbate. Now, if the symptoms don't exacerbate, then you have a couple things. Maybe it's a rapid resolving concussion. Maybe they're having so much autonomic dysfunction that their heart rate's inappropriately just getting so high. So you do have to kind of compare that to what their max heart rate would typically be for their age and other factors. But in general, if we're prescribing active recovery, we're doing exercise for 20 minutes a day, at least for 80 to 90%. I typically go to 90% of that threshold heart rate and do it to 6 to 7 days a week. We keep them on a heart rate monitor. We typically use stationary bike, treadmill, and walking. So again, non-contact activities. And, during this time, if it's too much, anytime the symptoms get worse during that, then we just stop it and we just tone down the target heart rate. Typically, before you do something like this, you want to review any type of orthopedic or cardiac issues, right? So if they have an underlying history of a cardiac issue, you might be so focused on the concussion diagnosis that you don't realize that they're being worked up for something else. So before you give them that, make sure they don't have any cardiac issues, any orthopedic concerns that could have resulted from an injury, to make sure that they wouldn't worsen that injury. We can repeat the Buffalo Concussion Treadmill Test or the bike test really as often as you want. There's some recommendations by Buffalo to separate it in time, but if you want to do it every few days, there's no harm in that. Or if you're not going to do it, you can actually just increase the target heart rate by about 5 to 10 beats per minute every 2 weeks. Now that's for us at the collegiate level, 1 to 2. That's a long time, But again, if you're crossing into the post-concussion spectrum and we're talking about protracted recovery, then that's something that may occur, and then you can guide your exercise program based on that. Typically, we look at physiological recovery as the ability to exercise to voluntary exhaustion at greater than 80% of age-predicted maximum heart rate for 20 minutes without symptom exacerbation. So again, with someone who's recovering from a concussion after we put them through an aerobic program, we would use that, Buffalo Concussion Treadmill Test to see, hey, if they're ready to start a return to play. Some further exercise considerations. Exercise intolerance after a sport-related concussion, does again appear to be related to autonomic cardiopulmonary control. So exercise tolerance, again, you have exercise intolerance initially, and then you have exercise tolerance thereafter. That does seem to signal a normalization of these processes. But the one thing I have to note, though, just because you have aerobic exercise tolerance that may come back after intolerance initially, that may not fully coincide with full neurological recovery. So again, this is the exercise portion of concussion. But again, there could still be other neurological factors that are just not lining up. So if you have someone, for example, who is a school athlete who's just not academically performing, and there's other factors that are, peeking through, just because they're physically ready may not mean that they're, mentally or behaviorally ready. So that's just another factor to look into. And just as a reminder for just concussion management, it is a multifactorial management approach focused on cardiovascular prescription and thresholds today, but there's still the whole other spectrum between vestibular ocular motor, rehab, the C-spine, any type of spinal issues, behavioral cog. What's not on here is the nutrition piece, the sleep piece. So again, when we do our concussion care through the Matthew J. Morahan Center, we're focusing on all these pillars, but again, looking at cardiovascular threshold and that resetting of the autonomic nervous system is just really critical. So the take-home points for today. So following a sport-related concussion, there's typically a loss of cerebral blood flow control. it seems that cerebral blood flow increases, during exercise. Deconditioning can affect cerebral blood flow control, and that can relate in a negative effect on autoregulation. And we would expect there to be deconditioning after a sport-related concussion to some degree. Doesn't have to be significant, but any degree can affect this. And it does appear that aerobic exercise at submaximal symptom exacerbation threshold appears to normalize local cerebral blood flow regulation, which can definitely help reduce those symptoms. And just the ability to exercise to exhaustion without symptom exacerbation is one definition of physiological sport concussion recovery. So with that, just some of my references, and I'm just going to jump out of this view here just to see if there's any questions, and I'm going to be try to be on later for additional questions if they're there.
Thanks, Dr. Krzysztofiak. I don't see any questions that have come in yet, but I know you're popping back in. Hold on, let's see if anything. So how do you handle return to play for contact headache?
Sure. So first of all, I put a lot of weight in the diagnosis. So if I'm concerned that there's an actual concussion, although it may not be all directly pointing to that, if there's any suspicion, I'm going to treat it as a concussion, and that's where that follow-up, the follow-up, takes place. So when I look at someone with a contact headache or just a tension headache, or not related to concussion, they typically have 0 to very, very minimal symptom score. They typically have a normal vestibular ocular exam. Now, people may have a baseline vestibular ocular issues, so having a possible baseline vestibular ocular exam on these athletes is critical. But if it's not available, then typically just, if you have a normal vestibular ocular exam, a normal balance assessment, if I have access to a King Devic and that's normal, and then if I'm going to work them up on the sideline, so now I have all these negative indicators, I'm going to have them do some change in elevations to see if I can elicit any type of vestibular ocular issues, so I can have them do some up and downs rapidly, have them do sprinting on the sideline. So now if I have pretty much like a very, very minimal symptom score, and it's hard to give a number on that, but typically what I see is literally like a 1 or a 2. I have pressure in the head, I have like a band-like pressure, and I'm having some neck pain kind of at the trap insertions. Then I have a normal vestibular ocular assessment. I have a normal balance exam. I have no red flag indicators. I have no distracting injuries to take away from missing a concussion diagnosis. And now I'm doing a physiological rapid test on the sideline between up and downs and sprinting and jogging. And typically, if that is all normal, then I'm going to say that person likely does not have a concussion. I'm going to have them return to contact play. Now, during that time, the best thing is that, especially with a large sports medicine team, you have now a million different eyes on that individual. So if anything changes, even while they're on the sideline, possibly waiting to get in, or they get in and they immediately see something different, that person is being pulled from the event for a reevaluation at that time. But typically, with all those negative indicators, with no change moving forward, and no increase in symptoms during an exercise tolerance, which can be done acutely on the sideline, they typically feel very comfortable with a non-concussion diagnosis and allowing that individual to go back to contact.
Thanks, Dr. Krzysztofiak. I appreciate that. We're really excited here at the center. It's both Dr. K and I just getting some of our abstracts published at the International Conference for Concussion and Sport in Amsterdam at the end of the month. I know Dr. K talked really heavily about the BCTT, and one of our research publications is going to be focused on the pediatric concussion version of that test. We've trialed a lot of the younger folks on a treadmill test, so we're really excited to be able to expand these protocols and share a lot of the findings and outcomes for patients with all of you in the future. So appreciate your time, Doc, and maybe we'll see you back later.
Thank you.
Thanks. Take care. All right, Dr. Kim, I think I see you on here. If you want to start queuing up your slides. While you're doing that, I'll introduce you so we can jump right in. Dr. Kim is going to be presenting on intersection syndrome today. Dr. Kim is sports medicine fellowship trained and board certified in primary care sports medicine. He's also down at our Eatontown location with our medical group and is employed under RWJ Barnabas Health. He was fellowship trained at Rutgers and Princeton, and he has experience at both the Division I and Division III level, including previous experience with Kane University. All right, Dr. Kim, I can see your slides, so it's all you.
Thank you, Diana. Thank you, Dr. Kristofiak, and everybody for having me on. You can see my slides and you can hear me okay? I'm just going to take that as a yes. No.
Yes, you're good.
Okay. All right, great. I'm a little stuffed up and a little congested, so I apologize if the way I sound right now. But yeah, we're going to be talking about intersection syndrome. And we'll start off with a case here. We have a 22-year-old female collegiate rower presents with right-sided dorsal radial wrist pain that's progressively worsened over the last 3 months. She describes the pain as constant, dull, and achy, and she's got occasional intermittent sharp-shooting pain up the wrist. No neurologic symptoms, so no numbness, tingling, and paresthesia. Of note, she did give birth to a newborn infant 3 months ago. So yeah, she's doing it all. She's raising a kid, attending school, and starring athletically as well. On exam, she's got mild swelling, tenderness to palpation over the distal radius, about 3 centimeters proximal to the wrist joint. She's got crepitus in that area. She's got 5 out of 5 strength, but she has pain to resisted wrist extension and flexion, and pronation and supination as well. When you perform the Finkelsteins test, she's got pain over the radial wrist and the forearm, and the negative Watson and the negative grind test. So based on that history and exam, you diagnose her with a case of mommy wrist or deep Dacre-Vein's Tenosynovitis. You decide to treat her conservatively with 2 weeks of a thumb spica splint and rest. 2 weeks later, she returns to you. She's saying she still has persistent pain, no improvement. So you decide to do a cortisone injection for Dacre-Vein's. She continues to wear the splint. And then she returns again 1 month later, stating that she still has had no relief. At that point, you astutely diagnose her with, the title of the presentation, intersection syndrome. And we'll talk about which elements of the H&P were red flags for this. So what is intersection syndrome? It's an inflammatory overuse condition. It's usually caused by repetitive wrist movements and wrist extension. It's common amongst rowers, weightlifters, skiers, racket sports players, and horseback riders, which I imagine has something to do with the reins, although I'm not sure. I'm not too familiar with that sport, but that's what I think is the cause is there. It was first described in the literature in 1841 by a French surgeon named Velpeau. So fun fact, he was actually the first person to also accurately describe leukemia. So yeah, talk about a very well-rounded physician there. So the term is descriptive. It describes where the first and second extensor compartment tendons intersect, and there's a friction there that eventually causes inflammation of the tendon sheath, also known as tenosynovitis. The diagram here kind of shows where those tendons intersect. So the first compartment tendons here, the second tendon compartments there, they intersect a little bit more proximally to the wrist there. It's important to note that there's a separate entity called distal intersection syndrome, which involves different tendons. For our purposes, we're primarily focusing on proximal intersection syndrome, or more colloquially known as intersection syndrome, because this is a little bit less common. And then there's another diagram again showing which tendons are involved and at which point they intersect. The differential diagnosis most commonly is confused with Dacre-Vein's Tenosynovitis. Another condition to be thinking about is Wartenberg Syndrome, which is an entrapment neuropathy of the superficial sensory radial nerve. That'll usually cause sensory deficits and paresthesias on the dorsal radial hand and wrist. Distal intersection syndrome, like we talked about, which involves the second and third compartment tendons. Arthritis of the wrist or the thumb, scaphoid fractures, or just a simple wrist sprain or strain. Talk a little bit next about the anatomy. So the dorsum of the wrist contains 6 extensor compartments, which contain tendons that extend either parts of the wrist or the hand or fingers. Starting from the most radial compartment, compartment 1 contains the abductor pollicis longus and the extensor pollicis brevis. So these are the tendons that are involved with de Quervain's tenosynovitis. The second compartment contains the extensor carpi radialis, brevis, and longus. So that's extending the wrist. Compartment 3 contains the extensor pollicis longus, which is an extensor of the thumb. Compartment 4 contains the extensor digitorum and the extensor indicis, so fingers 2 through 4. Compartment 5 contains the extensor digiti minimi, so the pinky finger. And compartment 6 contains the ECU, the extensor carpi ulnaris, which also extends the wrist. You may have heard the mnemonic, all peanut lovers enjoy peanut butter. And that's commonly, that's how people remember the tendons that are involved for de Quervain's. And I've added my own spin to that, except certain radicals to also signify the second compartment for the extensor carpi radialis. And these are all the tendons that are involved with intersection syndrome. So the diagnosis for this is mostly clinical. The location of the pain is predominantly what's going to give it away. So you can see here in the diagram the locations for where pain is typically localized for de Quervain's tenosynovitis. And you can see that for intersection syndrome, it's a little bit more proximal. Typically, it's described in the literature as 4 to 6 centimeters proximal to the radiocarpal joint. They may have swelling or crepitus over that area. They may have painful wrist and thumb extension. It's important to localize exactly where the pain is when you perform the Finkelsteins Maneuver. So the Finkelsteins Maneuver, as many of you guys know, it's when you close your fist over the thumb and then you passively extend it, usually by ulnar deviating. And you can imagine if you're performing this test, this test is pathognomonic for de Quervain's tenosynovitis, so that's immediately what you might think of. But for someone with intersection syndrome, they may have pain as well when you're doing this kind of test because a lot of the same tendons can be involved. However, the location of the pain while you're performing this test, it's a little bit more subtle, and that's kind of what gives it away. Again, there's no sensory neural component, so that's what differentiates it from Wartenberg syndrome. Imaging for this condition is not necessary, but it can be helpful to rule out other diagnoses, although getting an MRI for this is not considered cost-effective. Something that you can do very easily in the office is point-of-care ultrasound, and it's a great tool to localize the tendons and specifically exactly where the pain is. So yeah, ultrasound is a great tool, a great way to diagnose this. So when we perform ultrasound of the dorsal wrist, we always start with our initial landmark, which is Lister's tubercle. You can see that here. It's the bony prominence at the end of the distal radius there. So once you find Lister's tubercle, then you can orient yourself and find the other extensor compartments. So immediately radial to Lister's tubercle, you're going to find the second dorsal extensor compartment, which contains the extensor carpi radialis, brevis, and longus. Ulnar to the Lister's tubercle, you'll find the third compartment, which contains the extensor pollicis longus. And from there, you can identify the other extensor compartments as well. So when you're looking to find the point for intersection syndrome, you're going to start by finding Lister's tubercle. Then you're going to find that second dorsal compartment there. This is not Lister's tubercle here, by the way, just pointing that out. And then once you find the second compartment, radial to that, you'll find the first compartment, which contains the abductor pollicis longus and the extensor pollicis brevis. Once you find those two compartments, you simply just move the transducer proximally up the wrist and the forearm, and you'll see that point where that first compartment slides over or intersects over the second compartment there, overlying the distal radius. And then on the bottom here, you'll see this diagram again showing the difference between an asymptomatic side and the symptomatic side. So you see on the symptomatic side, you'll see that first compartment crossing over the second compartment there. You'll notice that the tendons are thickened and there's an increased fluid signal around the tendon sheath. So that's a marker of inflammation. Let's see, I think I had a video queued up here. Yep, so again, ultrasound demonstration showing that point where you'll see that those compartments intersect over there. So the treatment for this is mostly going to be conservative. It's going to be like your first, second, and third line of treatment. Typically always going to start with activity modification. So, for someone who's a rower or weightlifter or racket sport player, they're going to have modify their activity a little bit, continuously exacerbate the inflammation there. We're typically going to start by either splint or taping, which will help numb. So yeah, I prefer using like a thumb spica variety of a splint as compared to just a standard carpal tunnel wrist neutral brace. Have something that's going to immobilize the thumb as well. NSAIDs are also first line for pain and inflammation, provide applications to that. And then if those things don't work, the next step you can try is a cortisone injection or a hydrodissection procedure where we inject at first and second compartment tendon sheaths. I would highly recommend using ultrasound guidance for this to really localize exactly where the injection is. And the evidence does show that it is an effective treatment, provided the more conservative measures fail. Operative treatment for this is rarely indicated. It's really used only kind of as a last resort after your more conservative measures have failed, most likely a few times over. And this involves debridement and release of the second dorsal extensor compartment, followed by about 4 to 6 weeks of physical therapy or occupational therapy. This is just to kind of show how we perform doing an ultrasound guided injection. So you're going to be this here. And again, you find that intersection point where the first compartment intersects over the second compartment. Your needle is going to come in at an in-plane. So you can see the needle tip coming in through here. And this is your target area right in between the two tendon sheaths right there. And typically it's going to be a mixture of local anesthetic and corticosteroid. I believe that there's going to need to be a few more studies coming out with some of the more regenerative products like PRP and things like that to determine, whether that's effective. Although if you extrapolate it from, other conditions, that probably it could be effective as well. Now, this is a real life case that I had. I apologize for the image quality, but this was actually someone that referred to me in the office. She wasn't a typical textbook case, which, as we know, many times that's how it presents in real life. She was a 54-year-old obese woman, so not really an athlete. She was referred for right forearm wrist pain. She has a history of carpal tunnel syndrome on that side, and she had a carpal tunnel release surgery a few years ago. Her symptoms are different this time, so she's not having any neurological symptoms. Her pain is located mostly over that distal forearm area. There was no inciting event or injury, and she mostly has pain while doing dishes or lifting her tote bag. Her exam was pretty kind of non-specific and, diffuse pain and tenderness kind of all over. She was kind of a poor historian. So try to treat conservatively as first, put her in a thumb brace, and then give her some NSAIDs. That didn't resolve the pain, so she came back. At this point, decided to do an ultrasound exam. And so you can see here, again, not the best image quality, but there's the distal radius. You can see the shadow there. And then the first compartment intersecting over the second compartment there. That's really where she had the pain. It was kind of pinpoint tenderness, as I followed those compartments up and found the intersection point there. Thought it was a little unusual, but that's what the exam kind of showed. And so I decided to inject it, and you can see there's my needle tip coming in through there, right in between those two compartment tendon sheaths. This is a post-procedure image on this side, where you can see some of this increased fluid signal in between. That's where the injectate entered. So I used a mix of local anesthetic and corticosteroid, and used that to kind of hydrodissect that first tendon sheath off of that second tendon sheath. And so you can see that right there. And that actually took care of the pain. And she to this day still reports that she's doing very well. So yeah, as many of you know, that sometimes it doesn't really always present as a textbook case. This is where your history and physical exam is very important. This is just a slide showing, detailing what surgery would entail. So it's an incision right over that site of pain. And then they're going to debride and remove some of that inflamed tendon sheath from the second compartment as well. But again, that's kind of a last resort type thing. It's not very commonly done. This is a study from the British Medical Journal, which took a case series of of elite athletes that are competing for like national teams in Olympics and stuff like that. And these athletes really couldn't afford to miss any time. So there was a case series where they did early surgery for them. They determined how quickly they were able to return, and success was kind of determined whether they were able to compete in their competition, and they had some long-term follow-up as well. Not really, the best, strongest evidence study, but their kind of conclusion was that early surgery is not an inferior option, especially if you have an elite athlete that can't afford to miss time. But I think in real life practice, most of the time this is going to be managed conservatively. So I don't think surgery will become, a super mainstay of the treatment plan. So in summary, intersection syndrome is an overuse syndrome involving the first and second dorsal wrist compartment tendons. You can remember all peanut lovers enjoy peanut butter, except certain radicals. The diagnosis is clinical, so your H&P is very important, and ultrasound can be very helpful as well in the diagnosis, as well as the treatment, if you're doing an injection. And then conservative management is going to be your first, second, and third line before you try anything surgical. And that's about it. That's all that I have.
Thank you, Dr. Kim. Just giving a second here to see if we get any questions in the chat. Don't see any yet. I don't know if you're going to be on for a little while longer, but if any come in, we'll definitely queue you up. But thank you so much for that presentation. The videos and everything were really helpful. I know for me, who know nothing about intersection syndrome, so I appreciate all the extra images and stuff like that. And thank you for joining us this morning. All right, so we're going to move in next to Dr. Ashraf's talk, which is going to be on thoracic outlet syndrome. Dr. Ashraf, if you want to queue up your slides, we'll introduce you here. So Dr. Ashraf is fellowship trained and board certified sports medicine physiatrist. Dr. Ashraf works both at the med school at University Hospital. She's all over the place, actually. She's in Jersey City, she's in Livingston, and she wears many, many hats. She's also team physician for New Jersey City University, so I get to work with her very closely on that team physician contract. She's assistant professor of physical medicine and rehab at the med school since 2017. And she works with multiple Essex County schools, athletic organizations for sports injury, and does concussion management all over New Jersey, as well as with our Morahan Center. So good morning, Dr. Ashraf. Thanks for joining us.
Good morning. Thank you so much. Okay. So thank you, Dr. Kim, also for that great talk on intersection syndrome. We're going to be switching gears just slightly. So I think this topic, unlike some of the others, is not as I would say it's a little bit more nebulous because the incidence is just so much lower. So we are going to be spending a little bit of time about making sure we get the diagnosis right. So we're just going to go over some high yield points there. And then I'll start it off with, again, just to ground it in something, a little case of what is thoracic outlet syndrome. So since we're talking about overhead athletes, it's very common in baseball players. So if we have a 22-year-old college baseball player, reported that progressively during the season, by the time you get to about the 6th inning, noting that the skin of the throwing arm would begin to turn a little bit dusky, a little bit of purple, and the skin would look blotchy or patchy. And then he started to not feel the ball well in his pitching hand. He said if he was relieved and he would shake the arm repeatedly, the sensation in the hand would return, but it would take several hours afterward for the complexion of the skin to go back to his normal. So when we talk about thoracic outlet syndrome, we know that syndromes generally mean it's a constellation of signs and symptoms. It's not necessarily one specific thing every time, but most commonly what's occurring is a neurovascular compression. And if we think about our anatomy, which we're going to go into in detail in 1 second, we have the first thoracic rib, which is running medial to lateral, and then we have the clavicle coming right over it at a slight angle. And between those two bones often will be where the compression will be occurring. Again, the incidence being quite low, possibly more than this number here cited, 3 in 10,000 adults in an overhead throwing athlete or someone performing repetitive overhead activities, but still overall a pretty rare condition. Okay, if I could have you take away one slide from this 20-minute talk, it's this one. So thoracic outlet syndrome comes in 3 variations. By far the most common is the neurogenic variant. We also have a venous and an arterial type. When we talk about neurogenic, it's going to often present with some numbness in the hand, some weakness possibly in the hand, and we're going to go into why. But if we're talking about the brachial plexus being involved, it's the lower trunk of the brachial plexus, which is going to be innervating our hand muscles and the sensory feeling of the hand. Second to this would be a venous type, again, quite rare, but in baseball players, venous does present somewhat more frequently. This would show up with that dusky skin discoloration, sometimes cyanosis and swelling. An athlete may present with hand numbness, even in the venous subtype. However, the hand numbness is typically secondary to the swelling that's occurring because of venous congestion in the hand, as opposed to nerve compression. And then there's also a very rare entity, which is an arterial thoracic outlet syndrome. And this we should think of as mostly like an ischemic event. Okay, so the scalene triangle is the big target where often the neurovascular compression will be occurring. So the triangle is formed by the anterior scalene wall in the front, the anterior scalene muscle in the front, the middle scalene muscle as the back wall of the triangle, and then the base of the triangle being the first rib. Again, the anatomy here is really nicely depicting how the first rib and the clavicle are running in such close proximity that right between those two, the lower trunk of your brachial plexus can be compressed, or it could be your subclavian artery, or it could be the subclavian vein if somebody has very typical morphology of their vascular system. There are always aberrant pathways, and those might throw one for a loop, but we're talking about typical anatomical structures. And then why does it get compressed? So the bone could be compressing the other bone, and that's in that costoclavicular space that's identified on this image is a circle. You also can have it from heavy weightlifting or hypertrophy of the muscles. So the ones that are often the targets are your scalenes, of course, or your pec minor. And then sometimes there can be just a fibrocartilage band that's occurring behind the clavicle there, and that's giving compression, especially with activity. So all of these, while at rest, may provide enough space for the contents of the triangle. With aggressive activities such as overhead extension or such as repetitive neck extension, these structures tend to get compressed, and then they would present downstream with what we call a syndrome. Okay. There are a lot of case reports, and if you are familiar with TOS, you might have even been thinking about what about a cervical rib. So in general, cervical ribs are not that common. Less than approximately 5% of cadaver studies or population-based studies say that people would have a cervical rib, and this is a much more common thing in women. And if they do have one, it's often going to be bilateral. So this cervical rib is atypical, so it's an anomaly, and it's going to travel downward and articulate with your regular old-fashioned first thoracic rib. That can also cause compression, as you can see from the yellow arrows. It's right in the area where we're talking about the scalene triangle. And a few studies in emergency medicine have showed that if a person has a cervical rib and then they're subject to a whiplash injury, they are more likely to have thoracic outlet syndrome. We also talked about how the fibrocartilage band may be a source of pressure and additional cause for the structures to feel tense or taut as they travel through the triangle. You can also have increased muscle size, which is causing compression in that scalene triangle. And then, of course, something like a flex-X injury of the neck, a clavicle fracture, which has healed with callus formation or large pseudoarthrosis that can cause pressure in that region, and then repetitive upper extremity extension activities. So something like a baseball player winding up, a tennis player hitting a serve, these are possible risk factors for TOS in an athlete. However, there's also other types of occupational risks like repetitive stalking, repetitive lifting overhead for one's profession can ultimately lead to extra tension in this scalene triangle. The plain film here is just confirming what a cervical rib might look like. So sometimes if you have a high suspicion and you just get your x-rays, or if you find that there's an x-ray in the chart for someone who's had a chest x-ray, for example, for another reason, and you can identify that cervical rib, as you can see, the arrow on the right of the screen is showing that the left side is quite long, and that one is articulating with the first thoracic rib there and causing some possible source of compression. Okay, so when we go back to the different variants, how will they present? So when we talk about a lower trunk brachial plexus injury, we always think about hand symptoms. So this person might present with hand weakness, sensory deficits in the hand. And this is usually on the palmar side, but that's because it's the median, the ulnar nerve being involved. They'll also present with possibility of reproduction of their nerve-like symptoms with neck rotation or prolonged elevation of the affected arm in the exam encounter. As opposed to somebody who has a venous, they might present with more skin color changes. They might present with more of a, as you can understand, a vascular presentation as opposed to a neurological. But if there is numbness in the hand, try not to get thrown off because vascular congestion may lead to numbness in the hand. And then you might, in rare instances, especially if they're a very fair-skinned person, see that collateral vessels have developed as a way to compensate for that congestion. And then the arterial is really just like its own unique entity, and that the symptoms here almost always are due to a cervical rib, and the symptoms here can be quite spontaneous, so not induced by their preferred activity. On exam, you would check, you might find that the distal pulse on the affected arm is decreased compared to the unaffected limb. You might also see that the systolic blood pressure is going to be lower in the affected arm. And then coldness is a concern that you want to rule out something like a thrombus in the subclavian artery causing that lack of arterial supply. I put here Adsense because often in our training, we're taught about an Adsense test. So, and I specifically wanted to use this very old school photo of what an Adsense test looks like. So if you're familiar with Adsense, I would say put it on the back burner. It really has been shown to not be an accurate test. There's a lot of false positives on this test. Even if you use concomitant ultrasound at the same time to look at the arterial or the blood flow at the same time, it has not helped to improve the specificity of the test, giving you a lot of false positives. And so we don't want to use it as our primary diagnostic tool on physical exam. If you're not familiar with an Adsense test, then that's okay. Adsense, Ruse, they all have pretty low sensitivity specificity. But if you've never learned it, then I wouldn't even worry too much about picking it up in your arsenal. What is very helpful are electrodiagnostics. So if you're in this talk and you're one of those rare birds who's a physiatrist who also does sports medicine and performs their own EMGs and nerve conduction studies, then you're my kind of people. But if you are a healthcare practitioner and you're sending out your EMG, then I want you just to sort of get a little quick crash course in the two different parts of the test and what would be some of the more characteristic findings of neurogenic thoracic outlet syndrome. So since we're talking about lower trunk, it's really predominantly going to be your T1 and your C8 fibers, which are going to be feeding the hand muscles. If you were to perform your nerve conduction studies, which is what this picture right here is depicting, for example, you would see an absent or reduced ulnar sensory response, but a preserved normal median sensory response. And then if you were to do motor testing, again, with your nerve conduction, you would see both ulnar and median might be reduced or absent, but in this case, the median would be more effective. So interpreting these results would not lead you to think of something like cubital tunnel, carpal tunnel, Guillen's canal compression, because these are not findings that would correlate or match with those diagnoses. This is a very characteristic pattern, which should alert one with high suspicion to think about TOS. And of course, after you perform this, because we want to really get an understanding of how severe the injury is, a needle test would also be performed. So things that occur outside or once the dorsal root ganglion has passed are considered postganglionic lesions. And of course, this would be one of them. It is not a peripheral nerve injury. It's actually occurring prior to that. So in the brachial plexus. And what you would see if you were to needle muscles in the hand, ulnar innervated muscles would show abnormalities as well as median innervated muscles. And I just listed two of each because you'd want to test at least two different muscles in median and ulnar distribution, because they're both maybe getting fed by the C8 T1 fibers. And you would also want to test things like proximal to the brachial plexus, just to make sure that you're not missing something that's occurring at the C8 T1 level, for example, at the nerve root level, much higher up in the spine. So with the right electrodiagnostic approach, you could really tease out if this is neurogenic TOS. So this is also quite often employed. So something as simple as a diagnostic and or therapeutic scalene block can really help to confirm a neurogenic thoracic outlet syndrome. So here's a little depiction. You would try to block with, say, a longer acting anesthetic, the anterior scalene muscle under ultrasound. And if they had a positive response, meaning relief of symptoms, even temporarily, this would help to predict whether they'd be a good candidate for surgical decompression. I think it could be the individual practitioner's decision along with the athlete if it was going to be purely a diagnostic block, or if it's going to be, since we're going to be sticking a needle in your neck, we can make it diagnostic and therapeutic, meaning there would be two intervals at which you would ask about.
Dr. Ashraf, I don't know if you can hear me, but you froze a little bit there. I don't know if you're able to hear me at all. Okay. All right, we're actually about to go into a break in a few minutes anyway. So I think what we'll do, in the interest of time, I'll put us in practice mode and we'll come back right around 9 a.m. if that works for everyone. All right, so we'll see you in about 10 minutes and then we'll kind of work out some of the technical issues. Thank you. Okay, everyone, we came back just a few minutes early. Dr. Ashraf had some technical issues with her internet, so she is back online to wrap up her presentation here. So Dr. Ashraf, if you'd like to continue, you can go ahead.
Okay, so sorry about that. Okay, so is my video and audio good?
Yes.
Okay, so we were talking about ways to make sure that the diagnosis is right. If you're concerned about a vascular type of TOS, MR, angiography, venography is the way to go. This is a very unique study. You just want to reach out to your facility and make sure that they are comfortable performing it, but even a 1.5 Tesla MRI can perform it. So this is with contrast, and it's done in several positions. So the arm with abduction, the arm with adduction, really just to fully appreciate if there's dynamic change in the vascular structures. This is also very good at ruling out or ruling in TOS if it's the vascular subtype. Going back to our college pitcher, here's an example of his MR because he was presenting with the type that we thought was potentially a vascular, the less common type. So here, of course, is post contrast, and this is his arm up in the air. So as you can see here, we're seeing a lot of the blood flow here and then as well down here, but there's some question here, if you can see my mouse, about whether or not as it travels to the upper extremity, if the flow is sufficient. Okay, and then here's another example of an MR sequence. So of course, the radiologist is going to go through these cuts far, far slower, and they're going to really try to see if they can pick up any subtle differences. And this is all for venography. Okay, and then here's an angiography. So this is again post contrast. The yellow arrows are pointing to the subclavian artery. As you can see with the arrowhead, with the arm fully abducted, there tends to become this stenotic area right at this first clavicle on the patient's left side. And then you could see downstream that subclavian artery's flow is quite reduced. And so this would be a case of ATOS. Okay, so management, these would be like the sequences of least to most invasive. A lot of us think about surgery as the solution, but you'd be surprised with how many athletes get the wrong diagnosis for so long. They get diagnosed with carpal tunnel syndrome, they get diagnosed with other more common elbow pitching injuries. And then eventually, if you're seeing someone who's familiar with TOS, they get put in the right camp and they start down the treatment protocols here. So posture exercises in your therapy routine are very useful. So this is very useful for overhead athletes, but this is also very useful for musicians. So violinists and other musicians who are playing with their arm in abduction for a very long time tend to have some of these TOS symptoms. And so postural corrections are very, very helpful modifications to the way that they're performing their preferred sport. Again, if you were going to perform a scalene injection, which we do sometimes in the office with ultrasound, you could do it purely diagnostic with just an anesthetic. You could also put a corticosteroid in there, and then there have been a plenty of case reports, but only one well-designed randomized control trial using Botox for it. But you can understand in theory how well that this would work. If the hypertrophic muscle is the source of your issues, if you were to give Botox at the appropriate amount to the scalene, you could possibly reduce that tension or that stretch on top of your brachial plexus. Again, if you're talking about that arterial type, it's really making sure that there is no thrombotic event, and then possibly an anticoagulant. But this is a very serious conversation to be had between the quality of life for that person with TOS and whether or not the risk is very high. And then when we go to surgical decompression, often it's removing, if there's present a cervical rib, it's possibly removing some of the muscle. And these surgeries can be done with both of these things occurring at the same time or just one or the other. Here was a paper that made a little bit of a splash. This was earlier this year. It was a cohort study, so a small volume, because again, the incidence of this condition is quite low, but 27 MLB pitchers over the course of more than 15 years. They showed, to me, very astonishing results, but this is what the data showed, is that the return to play rates were quite high, and it was taking about approximately 10 plus or minus 5 months for the athlete to return. I would say anecdotally, when we look at players like on the opposite side of the screen, someone like Strasberg, it's been far longer, and it took far longer for them to land on the right diagnosis, but he has not fared quite well after having TOS surgery last year. The study did find, though, that their length of their career was not affected compared to controls. Their performance was not affected as pitchers compared to the controls, and that overall, they were quite satisfied with having the cervical rib surgery to decompress the region. So this is one very high profile example. So last year, Strasberg underwent the TOS surgery. This is, of course, after we all know he had elbow surgery, and then he had the hand symptoms of TOS misdiagnosed as carpal tunnel, and underwent that surgery with no benefit. Then he had 2 scalene muscles removed and a rib removed. And when he tried to return to play in June, we are not surprised, a lot of us, he had a stress fracture of his rib because there was so much muscle imbalance when he tried to pitch. So once again, he landed on the IL. Okay, so that's the talk. I'm happy to answer any questions. I don't want to run over into our next speaker.
Thanks, Dr. Ashraf. I don't see any questions in the chat. Just a comment though on your presentation. I remember that we actually had a Division I runner or a Division I rower come in that had thoracic outlet syndrome, but by the time they got to us, they were misdiagnosed with all other kinds of things. So like your topic was like screaming to me while you were talking. It's like there's just a lot of evaluation and precise intervention that needs to be done to figure this out, I feel like.
Absolutely, yes.
So good stuff. All right, well, thanks for joining us. And if you're still on with us later and we have any questions, we'll fire them at you, okay?
Thank you so much.
Take care. Okay, Dr. Spagnola, if you want to queue up your camera and your slides, we're going to give you presenter privileges to jump in here. And while you're doing that, I can introduce you. So Dr. Spagnola is going to be covering shoulder dislocation and instability today. He's board certified and fellowship trained in sports medicine and specializes in shoulder, knee, elbow, and adult reconstruction. Dr. Spagnola and his sports medicine team at Seaview Orthopedics are currently the school physicians for Manchester, New Egypt, and Rumson High Schools. And they also provide sideline coverage for Ocean Township High School and Barnegat High School football. Dr. Spagnola is also the team physician for Ocean County College. Very excited to have you today, Dr. Spagnola. So floor is yours.
Thank you very much for having me today. Let me start the video. Hold on. All right. Think we're good now? Great.
Yes, all set.
All right, again, thanks for having me. Today we're going to talk about shoulder instability and dislocations. Pretty common right now with our fall sports, very common in football, and then in the winter sports with wrestling as well. You'll see a lot of dislocations and subluxations. So we'll kind of do a 360 overview of the whole injury and what we can do to treat it. So initially, you have to understand the shoulder is the most flexible joint in the body. It has a large range of motion, so it's the most commonly joint that's dislocated or subluxed. The stability comes from a combination of the bony structure, the ligaments, the labrum, and the muscles. And we'll go over these individually, but mainly the labrum and the ligaments are the key to stability in the shoulder. The anterior inferior glenohumeral ligament is on the front inferior aspect of the shoulder, and it kind of raises up like a sling when you abduct and externally rotate the shoulder, and that's our primary stabilizer and the one that's most commonly injured with a traumatic dislocation or subluxation. You can also injure the posterior band of the inferior glenohumeral ligament. This is less commonly injured, but a lot of times overlooked and missed on exam. Happens a lot in a football lineman with two-hand shivers and hitting the pad. So it's a very common injury for them. The middle glenohumeral ligament is not a primary stabilizer, but the arm abducted to about 45 degrees becomes very important for that, preventing subluxations at that range of motion. The superior glenohumeral ligament will prevent inferior translation to the shoulder, but it's a weak ligament and not too important in the shoulder. As you can see, it's a very large ball that sits on a flat dish. If you turn it sideways, it looks like a golf ball on a tee. So it's inherently unstable by design. There is some what we call concavity compression stability, where the fluid between the humerus and the glenoid kind of create a little suction cup and help with some stability. Shoulder instability, occurs once you've torn that labrum or stretched out the capsule. Then with anterior, you'll sublux anteriorly with abduction, external rotation. And when you have a chronic unstable shoulder, the mechanism of rotation is disrupted, so you'll lead to rotator cuff issues. Usually in our younger athletes, it's not a rotator cuff problem, it's a labral problem, but with chronic instability, you'll get secondary cuff issues. Skip this, move on. So how do we become unstable? For the most part today, we're talking about traumatic dislocations, multidirectional instability with overuse is a whole nother topic in itself, and we're kind of limited by time. So the mechanism is usually a forceful abduction, external rotation to the shoulder, inferior distraction. You could have a violent adduction with forward flexion and internal rotation. This happens with seizures. This happens with linemen. And a posterior dislocation is commonly missed in the emergency room. The x-rays sometimes show that it's in. Looks like it's in, but it's really not. So you got to be really careful with posterior dislocations. The anterior dislocation, you can kind of see they'll have flattening of the shoulder. They're going to hold their arm kind of against the side. You might see a little bit of a sulcus sign. And the x-ray is pretty clear that the shoulder's out and dislocated with the empty glenoid fossa. So evaluation, kind of what we just went over, you're going to look for dimpling of the skin, limited range of motion. They're going to be very timid and pale. They'll hold the arm adducted and internally rotated. Make sure you check for pulses. You can have an axillary artery tear. With this, that'd be more of a surgical emergency. And a lot of times you can get a neuropraxia of the brachial plexus or the axillary nerve, and they'll have some decreased sensation over the lateral side of the arm. X-rays are kind of our first line of defense. So, if the shoulder's out, it's clearly, we'll see it on the x-ray. CT scans help us a lot, especially with bone loss, because a lot of time recurrent dislocations, you can lose that front corner of the glenoid rim. You can see here, it kind of comes out in the back here. It's a little flattened. And once you start losing more than 10 to 15% of your bony anatomy, arthroscopic procedures have a higher tendency to fail. An MR arthrogram is our gold standard. You can see a piece of the labrum floating in the breeze, and the contrast kind of surrounds it. Here on the axial images, you can again see the contrast underneath the labrum all the way down to the 6 o'clock position. So obviously our first line of defense is always non-surgical. Very tough to treat an overhead athlete completely non-surgical, but initially we want to relocate the shoulder. The most common way is traction, counter traction, where if you stabilize them with the sheet and pull with the arm, you'll pop that shoulder back into place. Another method is called the Stimson Method, and if someone could just push the wing of the scapula medial, it will free the shoulder to pop back in with just a longitudinal distraction. You can actually almost do this by yourself in the training room. If you had like a pail of water, a 15-pound weight, 20-pound weight, they can hold that for 10 to 15 minutes. And the shoulder sometimes just slowly reduces without any manipulation, or if you just push the scapula over a little bit, it'll slide right back in. So that's a reduction technique you can kind of do in the training room. The patient's heroic. They can kind of just grab their shin and kind of forward flex, extend their hip, and they'll kind of slip that shoulder back into place. But it's kind of a Mel Gibson thing, and not many people are going to do that on their own. So the rehabilitation, obviously in the first phase, we want to just let it calm down. There's been no studies that tell us that putting it in immobilization for 6 weeks in a sling or a brace will heal the labrum and prevent it from needing a surgical procedure in the future. So we just do a sling for comfort, start some modalities, and get them through that acute phase. In the advanced phase, we'll kind of go back to rotator cuff strengthening, scapula strengthening, get the terminal range of motion back, and start some sport-specific training. And return to sports. This could be once they have near full range of motion of the shoulder, 90% strength. They can perform their sport-specific activities without discomfort. They can go back to sports. This is one injury, unlike the ACL, we can get them back anywhere from 1 to 3 weeks in season. So a lot of football players can finish their season. If they need a surgical procedure, they can get it at the end of the season. So unlike the ACL where they lose everything right away, we can kind of get them back to get them through a season before they have to be sidelined for any surgery. Some positions, especially in football, the Sully brace, which is a brace that kind of straps on the shoulder and can limit some abduction external rotation, that can help, but it really restricts some of the shoulder motions. Not good for overhead athletes such as receivers or quarterbacks, but for linemen and linebackers, you can get away with a brace, which will help a little bit. Unfortunately, there's no brace that'll prevent recurrent subluxations. Therefore, they usually require stabilization. So here's an arthroscopic picture. You can see the glenoid, and this is a shoulder we might commonly see in a wrestler. Wrestlers tend to sublux and dislocate repetitively before they tell anybody. They're more flexible. Sometimes they spontaneously reduce, so they'll have multiple dislocations or subluxation episodes before we see them surgically. So here you can see everything's kind of frayed. The labrum is kind of completely detached. You can see all the way through the anterior scapular neck, and they've beaten up some of the cartilage rim. Another type of lesion where when the shoulder dislocates, it indents or damages the cartilage on the rim of the glenoid, in addition to having the labral tear. A more rare event is usually the pathology happens on the medial side by the glenoid. Sometimes it can tear the ligament off the humerus. We call this a humeral avulsion of the glenohumeral ligament. Changes the surgical procedure, tougher to do arthroscopically, sometimes need an open procedure. And if you don't address the lateral side, you will have recurrent instability of the shoulder. So there's always been a debate for a first-time dislocator to fix or not fix. I think the trend has been to fix all dislocators, especially under the age of 20, because the chance of recurrent dislocation is extremely high, almost approaching 100%. And I think fixing them gets them back within 3 to 6 months, and they cannot miss their next season if we do it quickly in the younger high school athletes. Having a rotator cuff tendon tear is uncommon in our young athletes. It's usually for someone who's over the age of 40 that traumatically dislocates their shoulder. Like I said, you could have secondary irritation of the rotator cuff tendon, but you would not have a full-thickness tear in a younger athlete. That's much more uncommon. Rotator cuff tendon tears increase to 40% in people who are over the age of 40. So surgical treatment, we want to stabilize the inferior labrum because this is where the ligament attaches. So you can see here, we would put 3 sutures in there, tighten up the ligament, which is the band right here, and recreate a buttress effect of the glenohumeral ligament to make it harder for the humerus to kind of jump over that wall anteriorly. They work, arthroscopic treatment works very well when there's glenoid bone loss in less than 15%, or if there's a non-engaging Hill-Sachs lesion posteriorly. Arthroscopic capsulotomy, we're just going over, we put these anchors in. Usually they're not made of metal anymore. They're made of a calcium phosphate that'll absorb over time. Posteriorly, when the shoulder dislocates, the posterior part of the humerus can indent itself over the anterior neck of the glenoid, causing what we call a Hill-Sachs lesion. This inherently makes the shoulder more stable, and the chance of recurrent dislocations is a lot higher. So when you have a large Hill-Sachs lesion, we can put anchors into the greater tuberosity, past the sutures through the capsule of the rotator cuff tendon. When we tie these sutures, it will take this soft tissue over here and lodge it into the defect. Once that's done, it puts a posterior force directed on the humeral head, so you won't sublux anteriorly. And when the shoulder rotates, this soft tissue prevents this indentation from re-engaging on the anterior rim of the glenoid neck and lessens the chance of recurrent dislocations or subluxations. For contact athletes, people have had multiple dislocations. Sometimes we have to revert back to an open procedure where we'll actually do the same procedure that we do arthroscopically now and put it through the suture, the ligament in the labrum. The sutures will go through them and tie them in an open procedure. Some people say the chance of a recurrent dislocation after open procedures less than arthroscopic, but I think in the correctly selected surgical candidate, they are about equal. The time that you need an open procedure is when it's been recurrent dislocations with bone loss or a large engaging Hill-Sachs lesion that can't be treated with the remplissage procedure that we just showed you. And we're doing more and more ladder J procedures where we actually cut the coracoid bone, turn it longitudinal, and sew it to the rim of the glenoid, or screw it to the rim of the glenoid. What this will do is widen the circumference of the glenoid, making the humerus have to travel further before it can dislocate anteriorly. And when you use the coracoid process, the conjoined tendon and the biceps tendon come off of it. So when you externally rotate the arm, it comes up like a sling and actually recreates the inferior glenohumeral ligament that was torn and stretched out from the multiple dislocations. And a salvage procedure, if the coracoid's not big enough because there's so much bone loss, we can go to an allograft reconstruction where we can use part of the distal tibia, which has a circumference that kind of matches the glenoid, cut a bony block and screw that in. That again will widen the glenoid and making it much more difficult for the humerus to travel anteriorly and sublux over the bony block. It was kind of a whirlwind tour of instability. I'd be happy to answer any questions. Thank you for very much for having me today. Hopefully that was helpful for everybody.
Thanks, Dr. Spagnola, for taking time out of your busy schedule to be with us this morning. We really appreciate it. That was a great talk. Let's see, don't see any questions. Oh, here we go. I think I got one. Okay, what is the rate of reoccurrence post-surgery given a healthy athlete with no bone loss issues or no Hill-Sachs lesion?
So the recurrence rate has really gotten down to about 10%, a little less. I think some people thought it was lower, but it's about 10 to 15% in open and arthroscopic procedures for a young athlete, first-time dislocator with no big Hill-Sachs lesion, no glenoid bone loss.
All right, awesome. Thank you. I think that was our only question. Thank you for joining us today.
Again, thanks for having me. Have a great day, everybody.
Absolutely, you too. All right, we're going to move into Dr. Parisi's talk on AC sprains. Dr. Parisi, I think I see you there. If you want to queue up your slides and start your camera, that would be great. All right, so Dr. Parisi is sports medicine fellowship trained and board certified in primary care sports medicine. He also previously was an athletic trainer, a board certified athletic trainer before he got into medical school, which is kind of cool. He's currently working out of Sports Medicine New Jersey in Morganville, New Jersey, and he is also employed within our system and our network. He's a school physician for Colts Neck High School, and I think he's ready to go. Dr. Parisi, if you want to share your screen.
Hello?
Yes, we can hear you.
Okay, can you see my slides or no?
Not yet. We just shared privileges with you. So if you want to hit that share button, either at the top or the bottom. Okay, here we go. Yep, you're all good now.
All right, you see it?
Yes.
Okay. Hello, everyone. Thank you for having us. So I'm going to talk about acromial clavicular joint sprains or separations. I have no disclosures to report or discuss. And today's learning objectives are to review the anatomical landmarks and structure of the shoulder and AC joint itself, to discuss the different etiology and epidemiology of AC joint separations, to discuss different management of AC separations, and to discuss differential diagnosis of AC separations. So first, I just want to go over a couple different cases to think about while we go through this presentation. So first, we have a 20-year-old collegiate rugby player who comes to your office with 3 days of left shoulder pain. It started after playing a game over the weekend where he was tackled and hit his left shoulder directly into the ground. He was unable to continue playing, comes in with 7 out of 10 achy pain that is located in the superior aspect of his shoulder that does not radiate. He has no, he reports loss of motion and weakness due to pain. He has no numbness or tingling. He's right hand dominant and no previous injuries to the shoulder. Our next case is a 42-year-old male cyclist, comes in with 3 days of right shoulder pain after a fall off his bike while trying to avoid a car that was trying to pass him on the road. He stated he hit the curb, flipped over the handlebars, and landed on his right side. He reports he's unable to lift his arm due to the pain. He did go to urgent care where x-rays were done and was given a sling and told to follow up with orthopedics. And our third case is a 18-year-old right-handed male football player who comes to your office with 2 months of progressive right shoulder pain with no injury or trauma. He states he's planning on trying to walk onto the Rutgers football team in the fall and has been hitting the weight room before and after school. He's also been doing drills with his position coach. He reports having pain with push-ups and not able to bench press due to the pain, and reports no loss of motion, denies any previous injuries. So going into the AC joint, it's a diarthroidal joint. It connects the anterior medial aspect of the scapula, the acromion, with the lateral aspect of the clavicle. There is a fibrocartilage intra-articular disc. This actually starts to disintegrate about the second decade of life. It's kind of synonymous with the meniscus of the knee. By the age of 40, it pretty much is done. So it actually decreases the AC joint space for that. At the AC joint, there's primarily a gliding motion, and you have about 5 to 10 degrees of rotation through the AC joint through there. Also, what we look at is the chloroclavicular distance. So it's usually about 10 to 13 millimeters in males and about 10 to 11 in females. Okay, so talking about the AC joint itself, talking about the static stabilizers. So we have the acromial clavicular ligament. This provides horizontal stability. There are 4 components of it: superior, anterior, inferior, and posterior. The superior and posterior aspects are the strongest portions of the AC ligament. Then we have the corticoclavicular ligament. This is broken up into 2 ligaments. So laterally, you have the trapezoid ligament, and medially, you have the conoid ligament. This provides vertical stability of the AC joint and the clavicle. Our dynamic stabilizers are the deltotrapezial fascia, the deltoid muscle, the trapezius, and the capsule itself. Oops, sorry. Okay, so our next slide. So, AC joint, sprains or ligaments are a traumatic injury to the AC joint, disruption of these ligaments. It can either be by a direct fall or blow to the shoulder with the arm adducted, or indirect mechanism is a fall on an outstretched hand. This leads to a drive of the humerus proximally into the acromion, pushing that clavicle up superiorly. This counts for 9% of all shoulder girdle injuries. It's more common in males than females, and more prominent in athletes compared to the general population. So on presentation, patients will complain about pain and swelling on the anterior shoulder, the superior aspect of the shoulder. There may be a possible deformity noted on inspection. They will have limited range of motion, especially with adduction and flexion of the shoulder. They'll report muscle weakness with the rotator cuff, with deltoid, and the special tests that are usually prominent are cross-arm tests and O'Brien's test at the AC joint. So some imaging that we like to get, it's always important to get bilateral AP views so we can compare the distance of the AC joint itself as well as that CC distance bilaterally. A Zenka view is really important to get. This really puts the AC joint into focus. It angles up about 10 to 15 degrees to really see. Also, MRI is useful for surgical planning or looking at the extent of injury due to the ligaments. And we could also use musculoskeletal ultrasound, again, to look where we might find some swelling around the AC joint. We could do a dynamic musculoskeletal ultrasound to see any instability with that. All right, so Rockwood Classification, this is the most common classification that we use to diagnose AC joints. So as you can see here, there's 6 types, and we will go into them individually. So first is type 1. This is usually a low impact type injury. It's a sprain of the AC ligament, but the CC ligament is intact. There's no AC instability. On X-ray examination, it'll be normal. Treatment for this is usually non-operative. You wear a sling for a few days for comfort, get them into physical rehab. We can also do a cortisone injection, and when they return to play, especially in contact sports such as football, we could always put a donut pad over that AC joint. Usually we're expected to return to play about 7 to 10 days after that. Next, we have a type 2 separation. So this is where there's a rupture of the AC ligament and a sprain of the corticoclavicular ligament. On X-ray, you can see an increased CC distance of less than 25% when compared to the contralateral side. However, you may not always see this. Again, treatment is conservative with rest, physical therapy, and return to play is guided by symptoms. With this type of injury, we're looking at more of a 2 to 6 week return, but again, it's really assessing their symptoms. All right, next we have type 3 separation. So this is a rupture of both the AC and the CC ligaments. There is superior displacement of the clavicle, and when compared to the contralateral side on X-ray, you'll see 25 to 100% increase in that distance. The treatment for this is very controversial. You have to take in consideration the patient themselves, what their activity level is, and what their goals are. There are a lot of studies coming out saying to do a trial of non-operative treatment versus early surgical management for this. This is one case study I saw. So it was a return to play in a professional baseball player. So this was a catcher who was running to first base, tripped, fell, landed on his shoulder. He was found to have a type 3 AC separation. After discussion with the medical team, they decided to go to non-operative route and got him into a rehab program. And as you can see here, this is kind of what he did. So the first few days, did some cryotherapy. They gave him some oral steroids. They did some microcurrent ultrasound and started passive range of motion exercises. By day 8, he was doing more active motion himself, isometric exercises. Then by day 33, he ended up starting his throwing program. He got to the minors about day 47 to start some batting practice, some DHing. Day 52, he was actually playing in a game and got hit by a pitch and actually fractured a carpal bone in his hand. So this actually delayed his return a little bit, but he was able to return to play by the end of the season, which his team did make the playoffs, and he was able to play both hitting and catching for them. So he was able to finish the season at a high level where he was. So going into type 4 type injuries, this is a rupture to the AC joint in the this clavicular ligament. This injury has a posterior displacement of the clavicle through the trapezial fascia. You normally will see skin tenting. It is very important to get the axillary view with this type of injury because we could really see where the clavicle sits. And then this treatment for this is operative. Going into a type 5 type injury. So this is a rupture of the AC and corticoclavicular ligament. There is injury to the delta trapezial fascia tear. Some people say this is just a more severe version of a type 3 with that deltoid and trap injury. You will notice a severe shoulder droop. And then there on x-ray, you will find a superior displacement of the clavicle, which goes over 100 to 300% of the contralateral side. And this was treated operatively as well. And then we have type 4, which type 6, sorry, which again it's rare. There is a tear of the AC and corticoclavicular ligament. The clavicle is actually dislocated inferiorly, and it can either be subcoracoid or subacromial position. Again, this will require surgery. So this is a little table that I kind of comprised from a bunch of tables that I was seeing in my research for this talk. So this just talks about the classification, what you would see in each ligament, the displacement of the scapula, and any x-ray findings and the treatment for it. There are limitations to the Rockwood classifications itself. It does rely on radiographs to see to predict what ligament is damaged. There was a study that was done where they took 15 shoulder surgeons and showed them 24 AC joint injuries. And on all those cases, they had about a mean agreement between the surgeons of about 62% on specific injuries. And then there was no case that they saw that all 15 surgeons actually all agreed on. Another study showed that there was a discoordinate between X-ray findings and MRI findings, where in about 52% of the cases, 11% of those cases were actually diagnosed as a higher severity of injury, and 36 were actually put as a lower severity of injury based on the MRI findings, what they found with the ligaments and damage with that. So differential diagnosis. So it's important to look for, coracoid fractures. This is usually more of a higher intensity of an injury. It's usually seen in more adolescents before the physes close. What happens is a lot of times is the coracoid actually avulses. So you have a superior displacement of the clavicle, but the coracoid distance is actually the same because there's no tear of the actual ligaments themselves. Next, we have distal clavicle fractures. Most commonly near 2A is kind of mimics these AC separations. And again, this happens when the fractures happen medially to the AC ligaments and the corticoclavicular ligaments. So the ligaments, again, are intact, but you have the superior elevation of the clavicle. It's also important to look at acromial apophysitis, pediatric physeal injuries, AC arthropathies in the older population. Another thing is for distal clavicle osteolysis. So this is more of an overuse type injury. So typically you'll have it in males who are weightlifters. A lot of times it does present bilaterally. You can find some findings on x-rays. You almost see like this flaming of the clavicle over here. I don't know if you can see my cursor on examination. But there will be no abnormal findings on inspection of your exam. Other things to look out for too are neoplasms, as they could affect bone reabsorption. You also want to pay attention to conditions like rheumatoid arthritis that could affect the AC joint. Hyperparathyroidism, you could also get reabsorption of that bone, causing some pain and a kind of osteolysis type picture. All right, so going back to our cases, so going back to our rugby player, so on examination, he comes in guarding his right shoulder. He has notable swelling over his superior shoulder, tenderness over the AC joint. He has 4 out of 5 rotator cuff testing when compared to the contralateral side. He does have pain with cross-arm testing and O'Brien's testing. X-rays do show a distance of 12 millimeters on the left shoulder and 10 millimeters on the right shoulder. Here's his X-ray over here. So his diagnosis is a type 2 AC joint separation. So again, this will be managed with physical therapy, possibly a cortisone injection to get him back, as well as a donut pad over the shoulder. Our next case, the cyclist who fell while trying to avoid an angry driver. So he comes in wearing a sling, guarding his right shoulder, obvious deformity noted at the right shoulder with skin tenting. He has a decreased range of motion, about 20 degrees of active flexion to abduction due to pain. Neurovascular exam is within normal limits. Again, here is his X-ray. So he is diagnosed with a distal clavicle fracture. And then our last case of the football player trying to get ready for the football season. So he has no obvious deformity noted. He does have tenderness over the anterior and superior aspect of the shoulder. He does have full active range of motion, but pain with adduction and horizontal adduction. He has 4 out of 5 deltoid and supraspinatus testing due to pain. He has positive cross-arms test, positive Hawkins test, negative empty can, and negative O'Brien's testing. Again, here's his X-ray, and his diagnosis will be the distal clavicle osteolytis. So really the take-home points is, management of type 3 separations are controversial. It's very important to have a talk with your athlete or patient to see where they want to go. A lot of times people may may go ahead with surgery for this for more cosmetic reasons, not always, functional reasons. But we can treat these with therapy, and players can get back to their high-level activity in the same season if done correctly and managed appropriately. It's important to take a good history and physical exam for the right diagnosis, as there's many different differentials that could occur at the AC joint. It's also important to make sure you get the appropriate imaging so we could adequately diagnose these athletes with the right condition so we know what we're treating. And again, it's important to have those conversations with your athletes and patients on what their needs and demands are. Thank you.
Great. I like your final slide,
Yeah.
Dr. Parisi. I feel like that all the time, actually.
Yeah.
Thank you so much for your presentation. You may have said this, I may have missed it, but are you what's the return to play recovery timeline with the non-surgical treatment for AC?
So it's non-surgical, anywhere from 1 to 6 weeks. Of that baseball player, he came back in more of an 8-week time period, but he also had complications with a hand fracture at that point. With surgeries, you're looking at about 4 to 6 months, depending on the extent of the surgery for that.
Got it. All right, cool. So good. You can actually get back during your season, like you said, with a lot of the non-surgical treatment.
Yeah.
All right. Well, thank you so much. I don't have any other questions that came in, but if you're going to join us for the rest of the day, if they come in, we'll let you know.
All right, perfect. Thank you.
Okay. All right. So we're going to move into our next presentation. Dr. Kripsack, you're up if you want to queue up your slides. I believe we gave you presentation privileges here. And while you're doing that, I'm just going to get you introduced. Dr. Kripsack is going to be presenting on rotator cuff and glenoid labral pathology in the overhead athlete today. He's board certified in family practice with a CAQ in sports medicine. He's previous chairman for the NJSIA Medical Advisory Board, and he's team physician for multiple local high schools for over 25 years. So we are certainly privileged to have such a seasoned veteran with us today. Okay.
Hello, are you there?
Hi. Yes,
Yes.
we can hear you.
All right,
You
great.
should,
Yeah, how do I get my slides up?
So you should see a share screen button at the bottom or the top there to share your screen.
Sharing. Share. File, edit, share. Here we go. So which one of these do I pick?
You should have a couple different windows. Just pick the one that has the PowerPoint there.
I'm not sure which one that is. Multimedia, whiteboard, application, file. Would it be file?
Should be presentation view, PowerPoint presentation view.
No, I don't have that as an option.
All right, so you know what we'll do? We're set to take a break in a little bit. So what we'll do, we'll take a 10-minute break. We're gonna come back around 9:55. And while we're queuing up Dr. Kripsak's slides. All right, so we're just gonna go into practice mode. All right, Dr. Kripsak, I think when we came out of practice mode, your slides went out again. So if you could bring them back up.
How's that?
Okay. Looks perfect.
Good.
You're all set.
Okay, great. All right, welcome everyone. Thanks for joining us for our conference today. So my topic will be on atraumatic shoulder pathology in the overhead athlete. This is something which I see a lot in my office. I take care of, high school athletes, college athletes, but a lot of weekend warriors. And this is something that is very common. I will say that probably the biggest boon to my practice has been pickleball, because everybody that plays pickleball at one time or another gets injured. So we see a lot of shoulder pathology, elbow, Achilles, knee problems. I think it's just that these people enjoy the sport so much that they just play too frequently. Because I hardly ever see any tennis players. It's just all pickleball players. Anyhow, I'd say probably 80% of the patients that I see either have a rotator cuff injury or a medial meniscal tear. So those are pretty common things. So I'm going to go over some stuff pertaining to the shoulder. So typically it's overuse injuries: baseball, tennis, swimming, volleyball, and of course pickleball, a very big one. Impingement is a big issue where we'll see some tissue damage to the supraspinatus, often the subscapularis, and the labrum. And this can be due to unbalanced strength of rotator cuff muscles, curvature of the acromion process, or scapular dyskinesis, where there'll be, the impingement that'll occur, and this can create small tears, tendinoses, and just a lot of pain. Patients will typically present with pain lifting their hand over their head. Usually when they say, "Hey doc, it hurts when I reach back to put a shirt or a jacket on, or I'm pulling the covers or the seatbelt," that's usually the big tip that the subscapularis is involved. And when they start saying that they'll feel like some clicking in their shoulder, that's usually a big tip that it's the labrum involved, or it feels a little unstable, or of course the dead arm. You notice that with pitchers, but patients will often say, even if they're just doing repetitive activity and they feel they get a dead arm in their shoulder, then you can think about labral pathology. So here's some acromion morphologies, and you see the type 1, you have plenty of space there for the supraspinatus to slide underneath. Type 2, it starts to get a little impinged, and type 3, it's like a razor in there slung away at the supraspinatus. So I always like to get x-rays to see what the morphology of the acromion is, because that can play a big part in making a decision on how to proceed with treatment options for the patient. So we always like to do a nice physical exam, and we start with the cervical spine. A lot of times shoulder problems can come from cervical spine issues. So I always like to have the patient do a nice range of motion, check deep tendon reflexes, and do a Sperling's maneuver. I've also come across a few times where I've had a normal cervical spine exam, a perfectly normal shoulder exam, and then it ended up being that they were having pain radiating up to their shoulder from carpal tunnel syndrome. So that's another thing always to keep in your mind. If something just doesn't seem to fit, doesn't hurt to do a Tenell's and a Phelan's. I mean, it's very rare, but I have seen it a few times, so I always keep that in the back of my mind. And then we examine the shoulder girdle, and you want to check for range of motion. Make sure they have nice external rotation, cross arm, scratch back. See if there's any limitations that can tip you off to what might be going on. Manual muscle testing. I'll do. I like to do supraspinatus testing with a full can motion with hands gripped, pointing upward like you're holding a glass of water and you don't want to spill it. Deltoid, subscap, with a lift-off test, and then special tests. And for impingement, I like to do Hawkins and Neers. For biceps, Speeds, Jurgensen, and a baseball test, which is really, I learned this from Dr. Steve O'Brien. It's something that he does. You abduct the arm 90 degrees, bend the elbow 90 degrees, and then resist as you tell the patient to simulate throwing a baseball. And if it elicits pain in the anterior shoulder, then that can tip you off to a biceps pathology. Labral tears, apprehension, relocation, O'Brien and Kim are ones that I like to do. Now, when you do an O'Brien test, it really everybody thinks it's for slap lesions, but again, according to Dr. O'Brien himself, this can tell you whether you have a slap lesion, a biceps injury, or an AC joint injury. So you got to keep that in mind, that if there's an O'Brien test, you have to review all three of those pathologies, that it's not always just a labral tear. For subscapularis, I like to do a lift-off test, and for AC joint, a cross-arm test or an isometric hand pull where they grasp their hands in front of their chest and try to pull them apart. And that will elicit pain on the AC joint if they have some acromial clavicular pathology. So again, if you do a really good shoulder exam, you can pretty much figure out what's wrong with the patient, and then you can go on to your imaging kind of to just confirm everything. But a good history and physical will probably allow you to diagnose 90% of the patients that you'll see. So imaging, you want to get x-rays, you want to get a glenoid fossa view, an axillary view, and a transscapular thoracic Y view. And the transscapular thoracic Y view is what's going to show you that acromial morphology, whether it's a type 1, type 2, type 3. Musculoskeletal imaging, we do a lot. I use an ultrasound like a cardiologist uses a stethoscope. Pretty much everyone that comes into the office that gets evaluated gets an ultrasound. The beauty of ultrasound is we can do not only static imaging, but dynamic imaging. And as I once heard in a lecture, it was a great analogy. It talked about the difference between MRI and ultrasound. So MRI is great for a lot of things, and ultrasound is great for a lot of things. And oftentimes you need the two of them to really get a good picture. Honestly, the best is to get an X-ray, ultrasound, and MRI, because each shows different things. So MSK ultrasound is actually better for tendon injuries than MRI. MRI is going to be better for bony lesions and labral tears. So if you're suspecting a labral tear, you really want to get the MR arthrograms or a T3 weighted MRI if you can't get an arthrogram. But with ultrasound, one of the beautiful things about that is doing the dynamic imaging, where if we move the joint around or stress it, we can find tears that we wouldn't necessarily see on an MRI scan, which is purely static. So going back to the analogy of the difference between MRI and ultrasound, if you're flying in a tourist plane and you fly over New York City, you'll see Central Park, you'll see Times Square. You get a nice image. You see that there's cars buzzing around, there's trees, there's buildings. You get a nice broad canvas. It's a beautiful picture. That's your MRI scan. Now, you land the plane and you go into Times Square, and all of a sudden you see the bright lights, you see people walking around, the colors of their t-shirts and the pictures on their shirts. Well, that's an ultrasound. So there's been many a time where I've gotten normal MRI scans, but there's definitely pathology which is picked up on ultrasound. And the patients will complain about having symptoms. And so we'll go ahead and treat based upon ultrasound a lot of times. But again, for labral tears, you can't really get into the joint as well to see the extent of a labral tear. So I really feel it's important to get MR arthrograms on anyone you suspect having a labral tear, which we do not uncommonly because we tend to see a lot of patients that have supraspinatus, subscapularis, and labral tears all together. It's what we call the triad because, or the trifecta, because it's very, very common. Another thing that I learned at a conference many years ago from an orthopedic surgeon is if you have a supraspinatus tear, chances are you're going to have a labral tear and vice versa. If you have a labral tear, there's probably a supraspinatus tear. It just seems that the two of those tend to go along with each other. I think it's because of the way that the humeral head moves in the socket. So if you have some weak posterior muscles and that humeral head tends to ride up and impinge, well, if it's impinging with the supraspinatus and the acromial process, the humeral head is probably also coming and impinging against the labrum. So you get that friction there. So if you look here, it's, instead of going like this, then you kind of come up and you get friction on that labrum as well as the supraspinatus. So those two tend to go hand in hand. So we always like to make sure, again, we do a good thorough exam and a good thorough radiographic evaluation to figure out our pathology. All right, so different pathologies that we'll see: impingement syndrome, rotator cuff tendinosis, which again, there's a difference between tendinitis and tendinosis. Tendinitis is going to be acute inflammatory process, which will usually subside in, a month or two the most. You can treat that with anti-inflammatories. A tendinosis is a chronic degenerative condition where you get some mucoid degeneration of the tendon. It's lost some of its elasticity. It can get hypertrophied. It's not going to respond to anti-inflammatories because it's not an inflammation anymore. It's a degenerative condition. So there's quite a distinct difference in how to treat those two. Partial rotator cuff tears without retraction, that's probably what I see most commonly in my practice. Full rotator cuff tears with retraction is common, or not as common as without retraction. Glenoid labral tears, AC joint arthritis, calcific tendinitis or bursitis is quite common. Bicipital tenosynovitis, we see a lot of. Subacromial bursitis, you got to look for that. Quadrilateral space syndrome, we don't see that very often. I've seen it a few times in some heavy weightlifters. That's where the teres minor becomes hypertrophied and can put pressure on the axillary nerve. And then scapular dysfunction, which can lead to the impingement syndromes and the labral tears. So it's important to keep all these in mind when you see a shoulder injury or have someone with a shoulder problem. So these are some of my treatment options that I deal with. This is kind of my flow sheet. For impingement syndrome, with a normal acromion process, relatively normal appearing tendons in the labrum, physical therapy, thrower's 10 is usually sufficient. You reestablish that yin-yang, push-pull with the rotator cuff tendons. You get the pressure off the supraspinatus. You get the infraspinatus working properly to depress the humeral head with abduction, and that usually works really nice. And I have patients come back 4-6 weeks later and they're like, "Doc, I'm fine," and you just tell them to continue with their thrower's 10 program, and that's usually sufficient to help someone with a impingement syndrome that doesn't have any real tissue damage. So the next one that I probably most commonly see is a normal acromion process with a mild tendinopathy, tendinosis. And again, we can start with physical therapy. You can do some prolotherapy injections with or without some needle tenotomy into the tendons. You can use extracorporeal post-activation therapy, which is fine. If there's some heavy calcification in the tendon, then doing a fast procedure is a nice option also. So there's a lot of things that you can do here to help the patient get better. Again, physical therapy is going to be a very important part of all this because, like I always tell patients that come in, especially athletes, pitchers, tennis players. You know, we can fix the problem, but if you don't correct what caused the problem to occur in the first place, you're going to come back and say to me, hey, doc, this didn't work. But the thing is, they didn't correct their biomechanics in a way to prevent this from reoccurring. So it's very important to have them continue after physical therapy to do prehabilitation, which are exercises that they should do to maintain normal biomechanics for optimal performance and diminish risk of further injury or recurring injury. All right, rotator cuff and or labral pathology. Partial rotator cuff tears with or labral tear in a normal acromion process. Typically, this is where I'm going to start to use ultrasound-guided platelet-rich plasma injections, followed by physical therapy. This works extremely well. I'd say I have close to a 90% success rate using this treatment. What the patients like is that as they come in from time to time, they can see in the ultrasound how their tissue heals, which is kind of a cool thing. And patient healing on this can really vary. The younger you are, the quicker you heal with PRP. You know, we'll get a kid in high school and they're better in like 2 to 3 weeks sometimes. They're fine. You get somebody that's in their 60s or 70s, you know, maybe they heal in 3 or 4 months. So it varies. The one thing you have to remember is there's been actually 2 very nice studies, one following tennis elbow injections with PRP with ultrasound, and another one following tennis elbow injuries with MRI. And in both instances, there was evidence of continued healing for up to 2 years. So one of the things that I always tell my patients after a PRP injection is to just be patient, because it could take 4 weeks, could take 3 months, could even take up to 6 months until they really feel good. Everyone heals at a different rate, and you just have to be patient with this stuff, because eventually everybody's pretty happy with it. A partial rotator cuff tear without a labral tear and an abnormal acromion, and I'm going to have them see one of the orthopedic surgeons, because I can go in and shoot PRP into that tear, but with an abnormal acromion, it's just going to tear again. And so that either has to be shaved down or excised, depending on the severity of hypertrophy or curvature or spurring of that acromion process. So that's an important distinction to know, because the patients have to pay for PRP. This isn't covered by insurance. So you really want to make sure that, you know, you take care of them properly and don't have them waste their money. So that's why it's important to get that transscapular thoracic wide view on this. A rotator cuff tear with retraction, that goes right to surgery. I'm calling the guys up and, hey, go on over and see one of the orthos, because we're not going to fix that. Once those fibers are snapped apart, you're not going to get it to heal back up with PRP. I have a colleague out in Pennsylvania that does this, and he'll inject them and keep their arm above their head for a week or 2. He says he gets good results, but I don't know how many patients are going to want to go through the post-procedure protocol for that. So for me, if you've got a retracted tendon, you're going for surgery. A labral tear with instability, you know, that's going to be a surgical consultation also. So, you know, again, you don't want to try to do something for someone that's going to have a poor outcome. All right, AC joint arthritis, physical therapy, corticosteroid injection. I sometimes like to use prolotherapy injections. You know, there's always the fear of with corticosteroid injections, will you weaken and soften the tissue and make it more susceptible to tearing later, whereas prolotherapy will cause an inflammatory response and create some healing in the area. So I tend to like to do those if it's not an acute injury, like an acute AC joint tear, as Dr. Parisi had discussed in his prior presentation. So an acute injury I might not be as inclined to, because it can cause a lot of pain. PRP injections can be helpful also, and also surgical intervention for really bad ones, or sometimes patients will just live with it. Calcific tendinitis or bursitis. If there's an amorphous calcium deposit that we see on ultrasound, we can do an ultrasound guided aspiration with a little corticosteroid injection. And that's very nice. We'll take a syringe with some lidocaine in it, inject into the area, and then flush it out, and you get this white toothpastey calcium to get out of the tendon, and the patients get a ton of relief from it. It's a really nice treatment, and they get immediate relief. With a solid calcific deposit, again, we'll do an ultrasound guided fine needle tenotomy where we'll go in with like we'll anesthetize the area, go in with a 20 gauge needle, try to break up that calcium deposit, so that the tendon's allowed to move more freely and they're not bound up. And we'll do a little corticosteroid injection. If that fails, we can have the patient go for a fast procedure where you use that vibrating needle to break up the calcium deposit and flush it out, which is a very nice technique. And then in the last instance, if it's a big hard rock in there, you might just have to get it surgically excised. Inflammatory bursitis, depending upon the size of them, we can do an ultrasound guided corticosteroid injection. Sometimes we'll aspirate, and if it's a large enough one, sometimes patients with bad osteoarthritis of the shoulder, we can get 5 to 15 cc's of fluid out and then do a little corticosteroid injection afterwards, and they get a lot of relief from that. The only problem is sometimes for the patients with that arthritis of the shoulder, these things are going to start coming back, and you have to look at other options. Sometimes I'll use a visco supplement, a hyaluronic acid, like an Orthovisc, and do that, and the patients can get relief out of that. And the only problem with that is, again, Orthovisc or any of those visco supplements are only covered by insurances for the knee. I'm sorry, so you'll have to discuss with the patient about a cost for that, which I think in our office is around $200, which isn't bad. And then we have the patients also go for physical therapy. Quadrilateral space syndrome, physical therapy is going to be your first treatment of choice, and you have to give this about 6 months of a trial. Anything less than that would probably be insufficient. If after 6 months the patient still has symptoms of pain in the posterior shoulder, down the arm, coldness, then you're going to want to send them for surgical decompression of the axillary nerve and or the posterior circumflex femoral artery, and that would work nice. I mean, we don't, again, this is pretty rare. We don't see it very often, but again, I have had a few cases of this with heavy weightlifters. Scapular dysfunction, usually just physical therapy is sufficient for this. And it's something that shouldn't be missed. You can do, you should always do an evaluation for scapular dyskinesis or dysfunction in your office, because when that's off, then your rotator cuff tendons are going to be off, and you're going to be more likely to get rotator cuff pathology. So it's always important to look at how the scapulae move and make sure they're moving synchronously and appropriately, and it's something that's probably not done as frequently as it should be. All right. Well, that was quick. Any questions on anything?
Hey, Dr. Kripsak, thank you so much for that great talk. We do have a question.
Sure.
You mentioned prolotherapy. Do you
Yes.
prefer prolotherapy over PRP, and why?
Okay, so prolotherapy is kind of a first line. We call it poor man's PRP. So if you have some really small tears that you see on ultrasound, or some hypertrophy or tendinosis of the tendon, then I'll go for prolotherapy. Listen, prolotherapy is very inexpensive. It costs like 25 cents to draw up an injection of that. Platelet-rich plasma can be much more expensive. Can range anywhere from $750 to $2,500 for an injection to do a kit. That's based upon, facilities. I know if you go into New York, because of the higher rent district, they may hit you for $2,500. Out in the burbs by us, I mean, I think the going rate's more between $750 and $1,000. But still, you don't want to have to spend $750 for something that you could easily fix with prolotherapy. Now, the other difference is time-wise. Prolotherapy is going to be a series of injections given every 3 to 4 weeks, and usually you need at least at least 3, sometimes 4 injections to get the results you want, where with PRP, usually a one and done, and then you just have to be patient for it to work. So prolotherapy is pretty much a first line treatment for tears that aren't very bad, but things that are more significant, I go to PRP.
All right, awesome. Thank you. That was the only question we got, but we're really, really thankful that you joined us. Aren't you in Colorado this morning or something?
I am in Colorado on my way up to Estes Park and staying at the Stanley Hotel, which is infamous for The Shining tonight. So,
nice. Ooh, okay. Well, perfect,
so that's my
perfect
trip.
timing with October and Halloween right around the corner.
Exactly. Listen,
right.
it was a pleasure. I hope it was beneficial and everyone learned a little something, and we'll see you guys later.
All right. Thanks, Dr. Kripsak. Enjoy
right.
the rest of your day. Take care.
Thanks, you too. Bye-bye.
Okay, Dr. Petrin, I see you've joined us. If you want to start queuing up your slides, I'll introduce you. Dr. Petrin is going to be covering finger and hand injuries in climbers today. She's fellowship trained and board certified in sports medicine and PM&R. She's also assistant professor of physical medicine and rehabilitation at Rutgers RWJ Med School. She practices both adult and pediatric sports medicine with RWJ Barnabas Health right here in Livingston. She's actually, I think, in the office next to me today, and non-operative orthopedics at University Hospital in Newark. She's also a physician on the USA Climbing Medical Committee and the USA Climbing Paraclimbing Committee. All right, Dr. Petrin, we can see your slides, so I think you're all set.
All right, great. Can you guys hear me as well?
Yes.
Okay, perfect. So thanks for having me. I think last year I spoke on turf toes, so something about the toes, and then this year talking about fingers. So the objectives for my talk are to introduce a little bit about climbing. Clearly that's a passion of mine, but as a great model for an upper extremity loading sport. So lots and lots of different injuries that happen in the upper extremities in climbers. I'm going to focus on introducing essentially pulley injuries, because those are the most common thing that happens in climbers, talking a little bit about what the finger flexor mechanism looks like. And then we're going to close it off with a little review, I think, more for people on the finger extensor mechanism injury. So we're going to be talking about sort of injuries to the extensors and then to the flexor system. My disclosures, I have no financial disclosures with either USA Climbing or IFSC, but I am heavily involved on various volunteer positions with both of those institutions. And so this talk is going to be a little bit about climbing. And so I don't know how much you guys know about it, but there's been essentially an explosion of the popularity of the sport of indoor climbing or sport climbing as a competitive sport and just as a participatory sport. So if you have not seen climbers in your office, I think they are coming to you. And if you look at the density of climbing gyms in our region, it's actually quite dense out here. And so this is not climbing outdoors. It's not free solo. It's essentially climbing on a plastic wall with a variety of different plastic holds that you can move around and make different types of routes. In this area, we have also a number of collegiate sports teams. So Rutgers has one, Princeton University has one, Rowan has one, Montclair City had one in New York City. That's close to us around here. Also, there's a ton of different collegiate climbing sports teams. And there's a number of gym-associated youth sports climbing teams. So Gravity Fall has one, Method, New Jersey Rock Gym. GOAT is a new climbing gym up in Hackensack. So lots and lots of climbing in this area, even though we don't typically have tons of rock formations. IFSC is the international governing body for the sport of sport climbing, and they've done a really fabulous push to promote the sport. It was included in Tokyo 2020, where it actually got really great reviews for viewership, and so it is now included for 2024 and on the lineup for LA 28, sort of home soil Olympics. If we generalize in terms of climbing injuries, which is more what's pertinent in terms of medicine, they're kind of split up into two mechanisms of action. The more acute or traumatic injuries tend to involve the lower extremity, versus the upper extremity really involving more these what we would call chronic or strain or training era injuries. clearly the mechanism that's the most obvious is, when you fall off. And so all bets are off when you fall off. It depends on from how high you're falling off, whether you're doing something that, you have some sort of safety device, like in this case, there's an auto belay there, or if you are bouldering, in which case, you're going to fall on the ground or on a buddy that's trying to help catch you. But you can get all sorts of trauma in this case, right? So it's a little bit unpredictable in terms of mechanism of action. The one that is the more predictable is what happens when you're hanging on, right? So you're hanging on stuff. It can put a lot of strain onto your shoulder, your fingers, your elbows, because all your forces, your entire body are being, it's being transmitted through that. And the sport of sport climbing has really evolved from just going, upwards to these very dynamic moves. So not only are you suspending your body weight for however long you're climbing per day, you're also doing a lot of these very dynamic movements. Catching yourself on a finger is going to be very tough like this for your little pulleys, and we'll talk about that a little bit later. And then the last one that we don't always think about, but a lot of your time as a climber is spent belaying people. And so in this case, in terms of the hand, it's not uncommon to see degloving injuries or some sort of injury where the rope, pulls or pinches you into the belay device. So you might think you're going to be safe there, but all sorts of trauma happens to the belayers at times as well. All right, so tendons and ligaments in climbing, right? So everything can either be injured traumatically, which is rare. Ideally, we don't want people falling and getting injured. But in sport climbing, more specifically, it's the chronic type of overload that happens especially in your upper extremity. The uncommon is common here, right? So yes, we see common things. We see rotator cuff tears. We see different types of epicondylitis, but we also see these finger pulley injuries that are very common in climbers, but not so much anywhere else. Finger growth plate injuries in your youth climbers, hamate fractures, lumbrical strains, brachialis strains, so things that are a little bit less common in other sports. The most common injury is going to be your pulley injuries. They make up, depending on what you're reading, about 15 to 20% of all the injuries. And we're most likely missing some of the lower grades of these because people just don't come in to be seen. So what is a finger pulley? So finger pulleys are essentially the straps that hold your finger flexor tendon onto the bone so that, when the finger flexor contracts, it doesn't pull the tendon this way, but it basically bends the different, your DIP and your PIP and so forth. But the way that this works is that they basically just act as a pulley, which is why they're called pulleys. And so they keep the tendon on the bone to give that mechanical leverage so that if you are loading that DIP, if you didn't have pulleys, right, the tendon would just go straight across. So lots of different biomechanical studies have been done into this. And so if your pulleys are intact, like they are here, when you load the DIP, the tendon basically follows the bone and that provides stability. So if you're hanging on your fingers, or it bends them. Whereas if you have more than one pulley insufficiency, or if they're torn, you will start to bowstring. So this is called bowstringing, where the tendon comes off. And in climbers, the one that's the most commonly injured is the A2 pulley, because it's one of the ones that has the biggest amount of stress through it. And then the second one most common is the A3 pulley. So it's different than what we would typically see in terms of pulleys. We see trigger fingers, right? And those occur at A1. So if a climber comes in, the biggest differentiator, or the biggest differential diagnosis is this, which is basically a tear or a rupture of the finger flexor tendon. So if some climber feels a pop and they feel pain sort of on the flexor side of their finger, that's your biggest question that you want to say, is this a pulley or is this a ruptured finger flexor tendon? Because they're going to be treated very differently. In the case of what a typical pulley injury looks like, there is a little bit of an acute on chronic mechanism, right? So a very healthy pulley tends to be able to sustain decent forces. It's when your pulley has essentially tendinosis or tendinopathy in it. It doesn't have normal loads because you've been overdoing it, or you're climbing more than it's been able to adapt. So it's usually an acute on chronic mechanism, but the climber will essentially reach for a hold, try to hold on, and feel a pop. So usually they hear or feel a pop, followed by pain and swelling over the area of the pulley. They can have some pain with finger flexion. And then if there's more than one pulley that's ruptured, you will see this bowstringing. But the biggest differentiator that you want to do on exam, right, is can they still technically bend the finger? And sometimes it's hard to tell because things hurt. But this is what pulleys look like in gross anatomy, right? They're these fine, thick ligamentous bands, and ideally they look this nice. Bowstringing, again, is when you have more than one pulley ruptured. So to review one more time the anatomy, the A1 pulley is where you would get like a trigger finger. A2 is the one that's most commonly injured in climbers. A3 is the second one. And honestly, all of these can be pulled off in a big trauma. When there's more than two injured, you're also looking at things like, was the volar plate injured? Is there a fracture somewhere? Is there a lumbrical injury? This is a pretty big injury when there's more than two at once. And then the FDP tendon, right? So something like a jersey finger if it avulses, or in the middle, it can also rupture, in which case it retracts. And so that's a very different type of injury. How do we diagnose these? Ideally, ultrasound, because it's non-invasive. You don't have to wait for like an MRI. If you feel like it's just an isolated pulley, this is great. If you feel like there's additional either tendon injuries, lumbrical injuries, fractures, and probably an MRI is better. So if things look pretty bad, get an MRI, but otherwise you could do an ultrasound. And what we're looking at is the bone tendon distance. And so if remember, the pulley is a strap that holds the tendon onto the bone. If that pulley is insufficient, it will lift that tendon up away from the bone. And so there are diagnostic criteria for when this is abnormal. If you're not sure what they are, it's a couple millimeters. But if you're not sure what they are, you can always compare to a different finger that's not injured or to the other side. This is what bowstringing would look like on ultrasound, where you have more than one pulley ruptured. You will have basically the bone tendon distance abnormal on more than one location. And we do grade these. So there's a number of grading systems that have been developed where grade 1 is basically just sprain. There's not necessarily insufficiency, but there's pain there. It can look thickened. It's sometimes tough to tell if it's not just tendinopathic. Grade 2 being a complete rupture of one or partial ruptures of two of them. Grade 3 being two consecutive ones. So in this case, you would have bowstringing. And then grade 4 is really anything where you have multiple ruptures and then other injuries like lumbrical muscle injuries or avulsion or other ligament injuries. What do we need to know about them? Well, one, you want to be able to recognize them, right? So you want to know that if a climber is coming in and they have sort of this flexor-based pain, it's most likely a pulley injury, not always, but most likely. And most of these are treated conservatively, right? So something that is fairly low grade, we assume it's a little bit of a training error. So the biggest thing that we want to do is rehab them, right? So early protected mobilization, we'll talk about what that means in a little bit, and then progressive slow loading. And it's really a training error. Somebody has overdone something. In the moderate grade, these are actually fairly serious injuries for climbers. I mean, it takes quite a bit of time to get back to climbing for these. So even a moderate grade one takes you out for about 3 months, even sometimes 6 months. It's a little bit of a shorter time of immobilization than for the extensor tendons, and we'll talk about this, but remember, you're doing basically 2 weeks of immobilization followed by kind of early mobilization. And the early mobilization is done with protected loading, and then we are progressively still loading them and protecting them at the same time for quite a bit longer until they can go back to climbing. High grade ones where there's loss of strength, there's bowstringing, there's other injuries, those typically go to surgery. The protected mobilization is, there's lots of different studies that have tested what is best to do. So if you remember the anatomy of the finger, what you don't want is to compress the arteries and the nerves around the finger. So what they've developed are these things called pulley rings, as well as the H-tape method. And so what that does is essentially act as a strap instead of the pulley to keep the tendon on the bone, right? So you're basically strapping the tendon onto your bone, but you're not trying to occlude your vasculature. So it has like a little cutout on the side. And you can make these, your occupational therapist can make these custom, they're, thermoplastic, or you can teach the athlete how to H-tape. So this is a method that people have studied and looked at the biomechanics of how far off, the how much protection this gives them. So that's pretty easy to teach people. You can also go on Amazon and just buy the Nice Climbs Pulley Pal, which gives you a big lump of these. So it's fairly easy to find these. So climbers will often come in with this already. They know that they suspect they have a pulley injury and they already have one of these. The biggest problem here is fixing training errors. So it's good if you know a little bit about climbing, but most of the time these pulleys are really overloaded in what's called the crimping position. And the crimping position is where you're trying to hold on to a teeny tiny ledge. And so you essentially bend your PIP maximally and you hyperextend your DIP. And then a lot of people will also pose their thumb across. And so this is really loading these pulleys in an awkward way. And that's where, if you're doing a lot of crimp holding, you can get into trouble. So you can try to adjust the way that you hold on to things. So open hand, which is less stressful on your on the pulleys, or at least doing some half crimps. The other thing is people who overdo it with what's called campus board training. So it's this, where you're essentially not using your legs, but you're just climbing up using your arms. So clearly lots of injuries will result from that, not just finger injuries, if you're overdoing this sort of training. And then fingerboard training, which is essentially focused on really loading those fingers and getting them stronger. But if you overdo it too fast, you tend to see some pulley injuries. So hopefully that basically covers a little bit about that, so you have an idea what pulley injuries look like. Again, I think they're coming for you. There's definitely a lot of this coming around. So we're going to cover briefly the central slip injuries. So I'm not going to cover any of the higher zone injuries or the proximal extensor tendon injuries. We're just going to talk about what happens right at the tippy ends of the fingers. So if you think about it, this is more common in things like ball sports. So either you're trying to catch a ball and your finger gets forced into flexion from extension. So the way that the extensor tendons anatomy work is a little bit different than the flexors, but here the dorsal aponeurosis of their tendons will split into these what are called lateral fibers at the PIP joint. There's a central slip that continues on, and then these guys go forward, and then they attach the DIP as your terminal tendon. Okay, so depending on where you injure the extensor hood mechanism will determine what the exam and presentation looks like. So if we think about it, this is something that can occur typically like with closed trauma in sports, so that jammed knuckle. Of course, open trauma, lacerations, you're trying to take out the pit of an avocado and you cut yourself, or you're chopping. And then we see this quite often, different types of extensor hood changes with rheumatoid arthritis, a little bit of a different mechanism there. But we're going to focus on the closed trauma here. And so this is what happens if you injure your joint at the PIP, or if you injure your extensor tendon at the PIP joint. What will happen is at that point you have what's called the central band. So that tendon part that goes across and then attaches right distal to the PIP joint. When that happens and the collateral bands are still intact, they will be able to pull the DIP into extension, but they will no longer be able to pull that middle phalanx into extension. And so what happens is you get this imbalance where you get what's called a boutonniere deformity. So most of you are familiar with this. The other one is the mallet finger, where the extensor tendon gets injured at the DIP joint. Usually that's the terminal tendon. So these are the lateral collateral bands that then have joined to the very tippy end. So either as an avulsion injury or as an extensor tendon injury. And so that will present a little bit differently. In this case, the DIP cannot be extended, but there's no real change there at the PIP. The biggest thing is to have a high index of suspicion for these. So if somebody comes in with a jammed knuckle, but you're like, he can kind of move things, make sure that you test for either an isolated central slip injury or that terminal tendon injury. And so the test that was described back in the 80s is the Elson test. There is a modified Elson test where you essentially have somebody extend or oppose their fingers bent at 90 degrees. And you are trying to see whether you can produce force. So can you extend that at the PIP joint and what happens at the DIP joint, right? So a normal intact central slip, if the central slip is intact, you will be able to feel the force being produced here, but the DIP is going to be kind of floppy. It's not going to be engaging because it's the central slip tendon that's engaging and the collateral ligaments are a little bit loose. If the central slip is injured, on the other hand, then the only thing that's intact are these collateral ones and lateral tendons. And in that case, the DIP will actually extend and you won't feel any force production up higher. So hopefully that makes sense. But that's what you're trying to reproduce. And ideally, you can put them over the edge of a table. Alternatively, you can have them test against each other like that. And then you're observing what the DIP is doing. You can ultrasound these and you can see little avulsions, you can see tears. Ideally, the best way to do this is in like a water bath, but you may not have this available, right? So the testing and a high degree of suspicion is pretty important. Most of the time, because if you catch these early, you can treat them quite well non-surgically. Most of the closed injuries can be treated non-surgically. If there's an open injury, some sort of laceration, any sort of additional vascular trauma, fracture, anything like that, that really probably warrants surgical consultation. But the non-surgical treatment is fairly easy. Essentially, what you're doing is immobilizing it for a very long time, essentially, right? So 24 hours per day for 6 to 8 weeks. And all you're trying to do is to oppose those ends of the tendons as much as you can until they scar down. So for the mallet finger, there's a variety of different commercially available splints. You can also make them custom, but you're just trying to essentially bring that DIP back into position and then hold it there. Usually that's about 6 weeks, and then you give them a nighttime splint for protection for another 4 to 6 weeks. Most of the time, kids don't get particularly stiff with these types of injuries. Some older people can get a little bit stiff and need therapy afterwards. And then for the boutonnieres, it's very similar, but a different type of splint. In this case, you usually want to have them do what's called daily mobility exercises for their DIP so they don't get stiff at the DIP joint as you're trying to heal this part. And that's it. So I hope that was a decent review for all you guys, and I'm happy to take any questions.
Thanks, Dr. Petrin. Take a look here. All right. I don't see any questions in the chat at the moment, but we will definitely queue you up if any come in.
Excellent.
Thank you so much for your time. Appreciate it. Great. Take care. All right. Good morning, Dr. Gatt. How are you?
Good morning. Good morning.
We're going to give you privileges to share your screen, and I'll introduce you while you're doing that, okay?
All right. Thank you.
So we want to welcome Dr. Gatt to talk to us this morning about bicep tendon injuries. Dr. Gatt is sports medicine trained and board certified in orthopedic surgery. He's an orthopedic consultant and team physician at Rutgers University, head orthopedic consultant for Rider University Athletics. He's also the chairman of orthopedic surgery at Rutgers RWJ Med School and an associate professor there of orthopedic surgery as well. And he's also program director of the Limb Salvage Program at Armed Forces Institute of Regenerative Medicine. Dr. Gatt, thank you so much for joining us. The floor is yours.
Thanks for having me, and good morning, everybody. So I'm going to talk about distal biceps tendon injuries, so injuries to the biceps of the elbow. We won't talk about the shoulder today. Sometimes this often seems like a relatively straightforward type of topic to cover, but I'm going to talk to you a little bit, maybe make you think a little bit about how we manage these rather than just a standard of fixing every one of them that we see. So I'm going to just start off with a case. There we go. This the history is a 45-year-old right-hand dominant male. He's an avid softball and basketball player, plays on a weekly basis. He was doing some work around his yard, picking up some heavy, large rocks. And as he picked one up, he kind of felt like it was going to drop, and he felt a pop and a tearing sensation in the anterior aspect of his right elbow. The next day, he started to notice some bruising in the elbow, complained of some cramping pain in the biceps, and noticed that his arm just looked a little bit funny to him. On physical examination, you saw in the prior picture, the classic is a large amount of ecchymosis in the anteromedial aspect of the elbow. The ecchymosis often extends well down into the forearm. There is a fair amount of forearm swelling often seen with these. and an obvious upper arm deformity. So what happens when the distal biceps tendon detaches from the radial tuberosity, the biceps migrates proximally. So sometimes I call it a reverse Popeye muscle, but people can see the obvious deformity. On examination, all patients, we'll talk about this in a few minutes, think that they're going to have trouble with elbow flexion, but when you examine them, what you're really going to notice is decreased supination strength. And a test that's been proven to be almost 100% accurate is the hook test. And anybody can try doing this to themselves. If you bend your elbow to 90 degrees and take your index finger and dig it underneath your biceps tendon, you can actually lift your biceps tendon up and off of what's called your brachialis muscle, which is the muscle underneath it. So if you perform a hook test and you don't feel that cord that is the biceps tendon, then you know the biceps is ruptured. If you're not particularly sure about a patient and the examination, you can always examine their contralateral elbow to see what the hook test should feel like, and then go back to the affected elbow and feel that the missing bicep. So in this patient, obviously, there was a missing biceps tendon. As far as when they come into the office, I'll routinely get x-rays. As an orthopedic surgeon, we have x-rays in the office. Sometimes the reason I get x-rays, I do want to make sure there's not some associated fracture. The biceps tendon attaches onto the radial tuberosity, Rarely you'll see a bone fragment avulsion with that, but that's extremely rare. Sometimes there may be calcifications within the tendon itself, and that may show you where the tendon is, but more often than not, the radiographs are normal. You'll see signs of soft tissue swelling. Ultrasound examination, if you're good at ultrasound and you have access to it in the office, it's an easy way to look at where the tendon is, because the tendon can stay relatively close to where it belongs, or it can retract proximally up into the arm. So here you can see a picture of an ultrasound with the tendon retracted up towards the top of the brachialis muscle. And in rare cases, if I'm not really sure what's going on, I might get an MRI, or sometimes more often for patient confidence, tell them that I'm sure you ruptured your biceps tendon. Everybody wants an MRI, so we get an MRI of their elbow. And if you see on this picture here, here's the biceps tendon retracted very proximally into the arm. This is your brachialis muscle. Normally, this tendon would be coming right down anterior to the brachialis, and right on that. The cut doesn't show you the radial tuberosity, but right onto the radial tuberosity. And clinically, you can actually feel that tendon kind of rolled up. When I operate on it, it's amazing how many times it just rolls up into a spool, and you can actually feel it up in their upper arm if they're not too swollen. So the MRI, from a cost effectiveness standpoint, I would tell you that I probably get an MRI 15 or 20% of the time, because basically most patients are confident, based on the deformity of their arm, my physical examination, and their weakness, that I'm correct in the diagnosis of a distal biceps tendon avulsion. So treatment options, and when I was a resident and through a lot of my career, I've always found that this is an injury that presents to an orthopedic office, and doctor says, "Oh, you tore your biceps, you need surgery on it." Well, throughout my training and in my practice, I was introduced to the non-operative management of biceps tendon injuries, and I have followed that for some patients, and I think the patients do really well, and we'll talk about that more as we go on. So for me, it is not an automatic that distal biceps avulsion equals a surgical repair. So if you think about the biomechanics of the biceps muscle, it's the strongest supinator of the elbow. And that's where the patients who are weightlifters, and they kind of get concerned, "Oh, I tore my biceps, I'm not going to be able to do curls anymore." But the truth of the matter is their elbow flexion strength will be just about the same. What people lose is supination strength. So patients ask, "Well, what deficit would I have? What won't I be able to do?" We always talk, and we talk about pipe fitters who have to turn things really hard, but something as simple as opening a very tight jar can be difficult without your supination strength. Now, the biceps functions as a supinator through a relatively limited range of motion. When the elbow's flexed past 90 degrees, now the biceps is relaxed, it really doesn't have very much supination strength. And when the elbow is more in extension, the supinator muscle is actually a stronger supinator than the biceps. But at around 90 degrees, 80 degrees, it's a very functional position for the elbow. The biceps is the strongest supinator. It does contribute to elbow flexion, but it's assisting the underlying brachialis muscle, which is our strongest elbow flexor. And as I said, supination strength does depend on elbow position, hyperflexion, and extension. You start to lose the biceps input into supination strength. Now, interestingly, if you think about it, you can think about it as simply as when you do a lift. If you do a biceps curl, your forearm is supinated, and that's where your biceps is really working. If you do a dumbbell curl, but if you actually pronate your forearm, then your biceps involvement is much less, and your brachialis is coming into play much more. So it's just those biomechanics. When you think about what people do, that's going to have an impact on how I might counsel them, whether they do operative or non-operative management. So the clinical considerations, age. I mean, the typical age of a biceps tendon avulsion is as a male patient in about their late 30s, early 40s into the 50s. That's where you see the biggest spike. But we do see some of these injuries in collegiate athletics, and I would say football is obviously the most common. We also see it in competitive weightlifters at a young age. Then I talk to the patients about their occupation. If they are, a heavy manual laborer where strength and rotation of their forearm is really important, bicep strength is going to be important to them. Hand dominance is really important as well, because if it's your non-dominant arm, I mean, you don't open a jar with your non-dominant arm, you open a jar with your dominant hand. So if it's a non-dominant arm, it's something to take into consideration. Then there's cosmetic considerations. There's a lot of people who spend a lot of time in the gym so that their arms look good. And if they have a biceps that's retracted proximally, that alone is a reason that they would not want to treat it non-operatively. If you are dealing with a younger patient, weightlifter, hopefully not a football player, but anyone who's younger than that late 30s age group, you do want to think about anabolic steroid use and maybe counsel them on the risks of anabolic steroids. So non-operative management is actually very easy. You and I say this a lot to people that I teach, like medical students, residents, but it takes me longer to talk patients out of surgery than to talk them into surgery. And this case is a perfect example where I tell people, they look at it, they see the deformity, they think of the biceps as a really important muscle for their arm, and like, why wouldn't you want to fix it? Well, one of the reasons is how easy it is to recover from the injury. Give them a sling for comfort. That's all they need. They can wear the sling if they want it, and they don't have to wear it if they don't want to. They can start early range of motion. They can start flexing their elbow, extending their elbow, pronating, supinating their forearm, and getting early range of motion is actually really important because the elbow does have a propensity to stiffen up. And if you keep it flexed for too long, getting full extension back can be an issue, and that's can be difficult to overcome. As soon as they're comfortable, and that's usually at around 2.5, 3 weeks, you can start some really light resistance exercises. Give them a 2-pound dumbbell and start them to do dumbbell curls, because then the really reason I'm doing that is to show them that their elbow is going to function relatively well and gradually let them return to full activities. And really in about 5 to 6 weeks, somebody who's a recreational athlete can be back doing almost everything that they normally do with very little discomfort. The issue obviously is the deformity of their arm. So here's a picture with the contralateral arm being normal, and this is a very, very retracted biceps. Oftentimes they don't retract that much. You'll see, but you still will see that the muscle balled up proximally in the upper arm. So non-operative management, easy, and there's no complications, right? People don't get wound breakdown, they don't get nerve injuries, they don't get heterotopic ossification, all kinds of things that can happen with surgery. And probably the one, if you want to call it, complication of non-operative management is they can get a little bit of a bursitis type of condition where the tendon is rolled up in their upper arm. And if they get that, usually one cortisone shot into that area knocks it out. And after that, they're fine. And I've treated, many patients non-operatively. There's one of the guys who he owned one of the Rutgers bars. And he said, well, I sling kegs for a living. That's what I do. And I said, trust me, at your age, you'll be able to sling kegs fine without any trouble. And, he did fine. The patient that I use an example, he's a person I work with in the medical school. He's back playing softball, basketball, never had any problems. I can tell you, I've never regretted treating somebody non-operatively. I never felt that I made the wrong choice. Now, that said, operative management tends to be the standard of care for this injury, and it is relatively straightforward. It's done the same day surgery. As I said, the tendon tends to be rolled up proximally in the distal aspect of the upper arm through a relatively small transverse incision, just distal to the antecubital crease. You can stick your finger up and grab the tendon and pull it down. Here's an example where the tendon has been pulled down, secured with sutures. And a long time ago, the exposure was much more extensile, but we've gotten to the point where we can do it through a relatively minimally invasive approach, especially if you do it acutely. If you do it acutely, there's the pathway or the tunnel for where the biceps tendon goes down onto the radial tuberosity. You can feel it with your fingers, and you basically get the exposure in a matter of minutes. Once you've secured the tendon with sutures, the current techniques that seem to work the best are to either secure it with what's called an endo button or a titanium button that's on the opposite side of the radial, drill through the radial tuberosity. The stitches go through the drill hole. It's a little narrow right here, and this button goes through vertically, and then you just pull some stitches and flip it, so now it's sitting horizontal, and that gives you unbelievable fixation. When I started using this technique, I feel like I don't have to protect the elbow at all. It's so secure. Another common way to do it is to use a biotenodesis screw. So you dock the tendon into the radial tuberosity, and then a screw fits into the tunnel, and that locks it in. And some people use belt and suspenders, use both the tenodesis screw and the endo button to fix it. But again, patients are usually in a sling for about a week. After surgery, you start passive motion. It's a little protected, but you basically want them to have full motion by 6 to 8 weeks after surgery. And when I say full motion, the most important thing is having full extension. They're going to get their flexion back, but I do tell patients that one of the potential complications of surgery can be a little loss of elbow extension. Not enough that it's clinically significant, but enough that you can notice it compared to the contralateral side. You'll start light resistance exercises at around 8 weeks after surgery, and most people can return to heavier resistance exercises at about 5 or 6 months after surgery, and you would expect a full return to sports or any athletic activities at around 6 months after surgery. There are complications associated with surgical fixation, and I think it's important to let patients know that that's the case. Years ago, I think there was the standard treatment was called a double incision technique because we didn't have devices like biotenodesis screws and endo buttons. So you had to make an incision on the back side of the forearm as well as the front side of the forearm, and that led to some more issues with either a radial. The biggest concern with that was something called a radial ulnar synostosis. By dissecting between the radius and the ulna, you could form heterotopic ossification that would fuse the radius and ulna together, and then the patients had no pronation and supination of their forearm. With the single incision techniques, as you can see on this list of complications, that essentially never occurs. Re-rupture, regardless of what technique you use, is excessively low, really, 1% on average, 1.5%. The posterior interosseous nerve is right near your surgical field if you're not careful. And again, this was more common with the 2-incision technique. If you ding the posterior interosseous nerve, the patients lose wrist extension, although usually that's just a traction injury and goes away on its own. There are a fair amount of minor complications. Post-op x-rays will show a little bit of heterotopic ossification at the site of the repair, which can cause some elbow stiffness or some bursitis-like symptoms. On the lateral side of the arm, the lateral anterobrachial cutaneous nerve tends to get stretched, so a lot of patients will complain of some numbness down the lateral forearm for about 6 or 8 weeks after surgery. That resolves almost all the time. Every now and then, the superficial radial nerve gets stinged, and so then they'll have some radiating pain down into their wrist. But again, that tends to resolve reliably at around 6 to 8 weeks after surgery. So, the major complications, the most significant radial ulnar synostosis is something that's really we're not seeing anymore, and the other complications are excessively rare. So if we look at, in the athletic population, as I said, probably the most common place you're going to see this is in the football population. And this was a study done by our colleagues up in Newark, return to play after biceps tendon repair in the NFL. And essentially, they had 35 biceps tendon ruptures over 16 years. All but one player returned to play. They returned to play at approximately 1 year, and regardless of their position on the field, they had performance that was equal to their performance prior to their biceps tendon injury. So this, at a high level, biceps tendon injury is, although it requires probably the reason it took them a year to get back is because the season ended, they get their surgery, and they have to wait for the next season. But it's they would be back, for the beginning of the next season. It's something that you can tell them they're going to do very well with this. And this paper went into a lot more detail. Their career length was as normal as control patients, so it's not something they have to worry as a career-ending injury. Non-operative management. One of the reasons that Dr. Tim Leddy, my partner, a long time ago, did a Biodex study on patients managed non-operatively, because in our practice we probably have more patients managed non-operatively than other practices, and showed with Biodex testing, which is isokinetic testing, that 90% of elbow flexion strength was returned, and even with an endurance, 90% of endurance was returned. A lot of times people always talk about, well, what's my peak strength? That's not sometimes as important as your endurance strength. And even forearm supination returned to almost 80% of normal. There was no loss of motion, no other complications. As I said, the length of incapacity was minimal, and the minor complaints probably had to do with the bursitis around the retracted biceps tendon. So this has convinced me that this is a very good option for the right patient. Chronic biceps tendon tears, every now and then people walk in, they tore their biceps, but they don't go to the doctor for 3 months. That's a little bit of a problem. It's hard to fix that. I tell them, just live with it. If they not willing to live with it, you can take the biceps tendon and tenodese it to the brachialis, give it a little bit better shape. It improves their flexion strength, really minimally at best. If you go down the reconstruction path with a semitendinous autograft or an Achilles allograft, again, they're going to potentially have problems with range of motion return, and probably not have the strength return they're looking for. You see, every now and then we see partial biceps tendon ruptures. Almost always treat those non-operatively. A little bit of rest, light resistance exercises, eccentric exercises. I have used the biologics, specifically PRP, to manage these, but in rare cases, if the biceps, on an MRI is torn like 75% of the way through and they don't respond to non-operative management, you can then go and do a repair. So in summary, acute elbow injury that occurs during eccentric loading, the pop, the deformity tells you it's a biceps tendon injury. Imaging really isn't that critical. There's excellent outcomes and return to play with surgical management, but don't forget that non-operative management is a very valid option in many patients that we see in the office. And that's about it. Thanks.
Thank you, Dr. Gatt. That was a really great presentation. I think biceps tendon injury is something I would not want to experience based on your talk. It doesn't sound like very much fun during the recovery phase, but I think hearing about all the non-surgical and surgical options was a nice opportunity, just giving us, some more insight on that. I think a question may have come in. Let me see here. When you use an endo button, when do you start passive range of motion right away?
Within 7 days. It's really just to get, you just want to let the wound settle down and let them go over the acute post-op pain. But again, my concern is loss of extension. So I'll get them going like 0 to 30, 0 to 45 right away. You can actually almost make the decision intraoperatively, because you can extend the elbow and look down at your repair and see if the tendon's pulling away from the radial tuberosity. So, technically they could start passive motion on day 1, but nobody wants to do that 1 day after surgery, and it's not that critical. But the important point I said I didn't want to drive home is the plan should be to have them have full extension by 6 to 8 weeks at the absolute latest.
Thank you so much, Dr. Gatt, for joining us. If any other questions
Sure.
come in and you're still on, we'll fire them out to you, okay?
Thanks.
All right.
Thanks for having me.
Yeah, anytime. All right, good morning, Dr. Rizzio. How are you?
Good. Good morning. How are you?
Good. You should be able to queue up your slides there if you want to work on that, and I will give the audience a little bit of information on you. So Dr. Rizzio is going to be covering UCL injury today. He is sports medicine trained and board certified in orthopedic surgery. He completed his sports medicine fellowship with the University of Miami. He's a former chief of sports medicine at Rutgers Medical School Department of Orthopedics, team physician for NJIT, and also has experience working with Keene University Athletics. He's also working on collaborative research with NJIT biomedical engineering on cartilage regeneration, utilizing stem cells and recipients of NH funding. So Dr. Rizzio, the floor is yours.
All right, thank you. So we're going to talk a little bit today about ulnar collateral ligament injuries in overhead athletes. And as you can see from the title slide here, if anybody knows who this is the guy that made it famous. This is Tommy John, who had one of the first reconstructions successfully back in the 70s. The anatomy of the UCL is really, it's a three-banded ligament with an anterior, posterior, and transverse or oblique bundle. The only real functional band is the anterior band when it comes to ulnar collateral ligament injuries in athletes. The anterior band extends from the medial humeral epicondyle and fans out to the sublime tubercle on the ulna in a broad insertion, and some newer data suggests that maybe its extension is distal to the actual sublime tubercle on a broader insertion point, so a consideration during surgical reconstruction. The major function of the ulnar collateral ligament is to resist valgus stress. It has its greatest effect between 30 and 120 degrees of flexion. And you can see from my slide here of the throwing motions, these three phases of throwing, the elbow is in those positions throughout those phases of throwing. So those are the highest risk points for UCL injury during the throwing motion. You have to remember, too, that we talk about UCL injuries in terms of pitching because it's probably one of the more common and popular things that people are aware of, but these also occur in other throwing athletes, such as javelin throwers and in quarterbacks, and sometimes in tennis players. The ulnar collateral ligament sees its major force and stress in the late cocking and early acceleration phase of throwing due to the flexion of the elbow and the valgus force at the elbow with throwing. So we were in a little bit of a UCL or Tommy John injury epidemic in the last couple of decades. There's been a five-fold increase in surgeries for ulnar collateral ligament injuries in athletes. And the interesting thing, or the somewhat concerning thing, is that the injury rates increased 5 times in patients specifically under the age of 18. About 5% of pitchers or throwers will suffer a serious elbow or shoulder injury during their career. And getting one of these injuries earlier on in your career certainly decreases your longevity in sport and ability to maybe get to the next level. So prevention is a huge part of this management. The biggest risk factors are the number of pitches, the frequency of pitching, velocity has a role, improper rest periods and adherence to pitch count recommendations and time off from throwing. Preseason preparation is certainly important. We want to make sure you have a strong core, strong lower body, as well as a strong upper body. And your throwing biomechanics play a significant role, but also the biomechanics of the shoulder and the entire kinetic chain have effect on future injury. So throwing 100 innings a year or more puts you at a 3.5 times risk of injuring your ulnar collateral ligament. Recommendations are not to pitch more than 8 to 9 months in a given year, and it's clearly not recommended to participate in multiple teams. Any of us who have kids that participate in baseball, we know the pressures to be involved in club sports, do tournaments, do showcases. Patients are often, young athletes are often, encouraged to participate on multiple teams because they're good. They're sometimes encouraged to pitch in more than one game because, you didn't throw that many pitches in the first game. But these are really, really not recommended activities. And part of this comes from the fact that the coaches and parents have a misconception about what's really dangerous to do. But the truth is, too much throwing, too many months a year, and too many teams is a bad thing. And of course, resting in between outings, and there's online resources for this for your children. So I mentioned velocity. The ulnar collateral ligament can fail acutely with throwing above 85 miles an hour. The problem with this is that I don't think you're going to convince anyone to stop throwing fast. The entire sort of interest of the colleges and major leagues they want people who can throw fast. So you're not gonna decrease the velocity of pitchers, but you can help them rest. You can help them condition preseason and prevent this from occurring. The last thing, I'm sorry with the slides. The last thing is biomechanical is, and related to the shoulder in particular, is that pitchers have an adaptive change in their motion. They tend to get increased external rotation and can lose internal rotation. And when this becomes a major difference between the two sides, you can wind up with something called a glenohumeral internal rotation deficit. And having this deficit above about 15 or so degrees compared to the other side puts your elbow and your shoulder at risk for injury. So having proper stretching and a proper evaluation, including the entire kinetic chain, is important when seeing these athletes. So the evaluation and management, we basically start with a good history and physical. Injuries occur either gradually or chronically or acute. The acute ones are often a single throw, felt a pop, dead arm, couldn't go back to pitching that day. The ones that we see frequently as well are the chronic injuries where an athlete has increasing pain with throwing over many months. They have often a decreased velocity, decreased accuracy. They're ineffective on the mound, and pain has been increasing, and sometimes to the point that they can't pitch any longer. Usually the location is medial. That's where the ligament is. It could be anywhere along the ulnar collateral ligament from its insertion on the epicondyle down to the subline tubercle. Many patients early on will have ulnar nerve symptoms, which frequently go away with rest, but it is a common problem, and it's felt to be traction on the ulnar nerve from the valgus laxity when they're throwing. And this can cause symptoms very similar to cubital tunnel syndrome. Physical exam is a basic physical exam we do for any body part, including range of motion, but specifically for the ulnar collateral ligament, we're assessing it on valgus stressing. We're palpating the area to try to determine where the tenderness is. Also, with these methods, we're trying to get a feel if there are other differential diagnoses at play here, such as flexor pronator tendinitis, valgus extension overload, and other issues unrelated to the ulnar collateral ligament. It's always a good idea to check the cubital tunnel for a Tinel sign, and often you can get an idea if the ulnar nerve will sublux out of its groove as well, which becomes a little bit more of a thing that you need to know if you're going to perform surgery. The milking maneuver is basically a static valgus moving stress test where you hold the patient's thumb, apply pressure to the lateral elbow in about 70 or so degrees of flexion, and you pull on the thumb to recreate that valgus stress from pitching. When you do the same test but moving the arm through a range of motion from about 30 to 120 degrees, you can increase the sensitivity of the test and also increase the specificity. So when you have a positive valgus moving stress test or milking maneuver, that's a high concern for ulnar collateral ligament injury. The imaging studies we typically employ are your X-ray, dynamic ultrasound in some cases, and MRI with or without intra-articular contrast. The reason I like to get an X-ray is because, as you see here, this is a 15-year-old male active baseball participant who had elbow pain for several months, but gotten worse recently. I got an X-ray, and you can see here that he has a calcification within the ligament. This does not appear to be an acute avulsion injury from the epicondyle, which can occur because you can see here that the ligament is, the bony calcification is well corticated, rounded, and smooth. Sometimes you can perform a stress test of the elbow under X-ray to look for medial widening. I haven't found this to be particularly useful. My fellowship directors, we did a lot of ulnar collateral ligament surgeries down in Miami, and they did a pilot study with this and really did not find it to be helpful in the decision-making process. Ultrasound is interesting. You can do a conventional ultrasound where you can evaluate the ulnar collateral ligament. You see the medial epicondyle on the ulna, and this is the joint space here. But if you can get this done dynamically where a stress is applied, a valgus stress is applied to the elbow, you may see widening and increased laxity real time under ultrasound. And if you can get a really good ultrasound like that and someone really knows how to use the machine and do that stress at the same time, it's a very valuable tool and gives you some real-time data on what the ligament integrity is like. MRI, though, is still generally considered the most reliable. An arthrogram using intra-articular contrast will improve its sensitivity and specificity. This is an elbow MRI, and over here you see the ulnar collateral ligament attaching from the medial epicondyle to the subline tubercle, and has a relatively uniform black appearance and is a pretty normal MRI. The classification of injuries generally are based on severity, whether it's a low-grade partial or a strain, high-grade partial or complete. It can be further classified into location, whether it's a proximal, mid-substance, or distal rupture. The treatment algorithm usually starts with an attempt at non-operative management, period of rest, stretching, mechanical improvements, strengthening, and then a throwing program. These are good for your partial tears. However, complete tears tend to get pushed into the surgical pathway a lot sooner. But also you need to consider where the patient is in their career. Someone who's looking to play the last season in high school or their last season in the pros or college, you would probably try non-operative management because the ulnar collateral ligament surgery is the ultimate sports surgery. It's really only necessary for an athlete to be able to throw. You can live with these tears for the rest of your life and do everything you want to do in life without any problems at all. So subjecting someone to a surgical rehab for a year in their last year of their career is probably not reasonable. So non-operative management, again, is rest anywhere from a couple of weeks to 6 weeks, but longer rest is obviously better. Progressive stretching and strengthening. You have to include the hips, shoulders, and spine, or torso or core with all of this, because the throwing velocity and power really comes from the core and the lower extremities as much as from the arms. So you really have to have everything well balanced. And then if they're pain-free and doing well at about 4 to 6 weeks, you can initiate a throwing program, and you can progress that throwing program if there's no pain during the treatment. Generally, non-operative results are okay. I would say it's a 50-50 chance with partial tears. Proximal injuries tend to do better than distal injuries, and that's probably due to the blood supply and inherent healing capacity of the ligament proximally versus distally. And in a study there that categorized the different tear locations, about 75% of distal partial tears or distal injuries fail non-surgical treatment. Complete tears tend to always fail. There are some exceptions, but in general, in baseball, a complete tear is not going to do well. And depending upon your sport, if you have a sport where you're a quarterback that uses a little bit of a different throwing motion, a little bit less frequency of throwing and velocity of throwing, and uses a lighter object and like a javelin thrower, they're more likely to recover than a javelin thrower, say, who throws a very heavy javelin, and versus a baseball player who throws 70, 80, 90, 100 pitches a game at super high velocities. We talk about orthobiologics. It's in every topic these days. It's for every condition. Certainly, the PRP and stem cell literature has been expanding. It's improving our knowledge base in a lot of different conditions, but it is still a little bit unknown how effective it is for every condition. These 3 studies point out excellent results with PRP injections. The problem is that none of these studies had a control group, so no one really knows if these patients would have done as well just on their own as they would with the PRP. So those studies are lacking, but on the way. And the middle study here by Dines, which was interesting, showed that all of the distal ruptures failed PRP injections, and I don't ever give a PRP injection to an athlete for a distal tear, as much as they may want it. Operative treatment for when all else fails and things aren't getting better, you have a complete rupture. The generally accepted technique is a reconstruction. The original technique described by Job back in the day was a figure of 8 medial common flexor mass elevation and reconstruction. That has now been modified to a muscle splitting technique. Then there's the docking technique, which is my personal go-to. I think it's an excellent choice. It allows me to tension the graft easier, and I find it very reliable. People are playing around now more and more with interference, hybrid fixation. Very, very possible to be just as good, but some of the results are still forthcoming. Repair has made a comeback in the last, several years, and it's very, very effective, at least in my experience, with proximal or distal avulsions. I've not done it for any mid-substance repairs. I don't think it works. One of my colleagues from fellowship and I, with our fellowship directors, had originally reported on subline tubercle avulsion repairs back in the early 2000s and had excellent results. This technique has now advanced to include a braided suture internal brace to support healing and strength. These are just some pictures of what the techniques look like. You can see here the Job technique is a figure of 8 weaving graft, which obviously places the bone at a little bit more risk for possible tunnel breakthrough and damage, but also required a very extensive release of the tendon. The docking technique is done through a muscle splitting approach, and you can see here it's 1 tunnel and then a single tunnel here with 2 little drill holes to tension the ligament by individual strands, which is a nice technique, and then it's tied over the top here. An interference screw can be added if necessary. And then a similar technique using a hybrid fixation where distally it's a single tunnel in the ulna, and then the docking technique up above here. Really what it comes down to is the surgeon has to do what he's most comfortable with, and if he's comfortable with it and gets a good reconstruction with a good graft, results should be fairly reliable. This is a case of mine. It's a 20-year-old college pitcher who had chronic medial elbow pain for a year or more before they came to the school. Ulnar nerve symptoms were sort of variable but not consistent. And in this case, you see here, although the ligament looks reasonably intact, there's a lot of signal abnormality in the ligament and some partial tearing up here and maybe distally. The whole ligament looks involved. I didn't think that a repair or non-operative management would continue to work, even though we tried non-operative management for a while to keep him in the game. I ultimately did a palmaris longus autograft reconstruction, and you can see here the docking technique. It goes through the sublime tubercle. These are the 2 limbs being pulled up here. These are the sutures in the medial epicondyle, which would be tied over to secure the graft in its tunnel. And then usually I put some stitches between the limbs to make it a little bit more solid and tighten it up. And then I close, which you don't see well here, I close the native ligament up over the top of it to add some blood supply. This is your antebrachial cutaneous nerve medially, which we try to protect. This is another case of mine this is a javelin thrower in college, was throwing the javelin. She felt a pretty sharp pop. It was an acute injury. There was no prior symptoms, no ulnar nerve symptoms. And in this case, I did a repair with an internal brace. And what we see here on this first slide is I'm holding the ligament here where it avulsed off the sublime tubercle, exposing the joint here. This is the medial epicondyle and ulna in the trochlear notch. This is the ligament pulled out to length here. It's completely avulsed from the bottom. I put some sutures in it, and the sutures then are tacked down to the sublime tubercle. You can see the sutures here in the ligament in a whip stitch locking fashion, connected to the sublime tubercle. And then this here is the internal brace, which gets docked in proximally, and then will get docked in distally over the ligament to add a layer of security. So in general, in a more recent systematic review, including 2019 patients from several studies, the average return to play rate is 86.2%. That's pretty excellent, but certainly not 100. College athletes return to play at a higher rate than high school or professional. And the docking or modified Jobe technique had the highest return to play. There's some conflicting data on performance. One study in 2014, although many returned to play, a lot of these pitchers wound up having a lower ERA, a higher walk and hit per innings, and fewer innings pitched than they did previously. Then in this study in 2014, again, there was a 50% decreased performance across parameters and almost a 50% return to the disabled list by the pitchers who had a reconstruction in the MLB. In contrast, this study with 790 patients, Erickson found fewer losses, a lower ERA, and less walks, hits, and home runs after their reconstruction. Sadly, younger athletes return at a much higher rate than older athletes. Once you get to above 30, you almost have a 50% chance of not making it back. And some outcomes in general, urban myths about UCL reconstruction is it doesn't improve your velocity. Getting a prophylactic ulnar collateral ligament reconstruction, which, believe it or not, I've had parents ask for in my office over the years, does not improve the kids' velocity and does not improve their metrics. So it's you're never going to do better than what nature gave you. So in summary, there's been an epidemic of UCL injuries in the last 10 or so years. Prevention is much better than the cure. A non-op trial for all partial tears is reasonable unless it's a distal tear. I think that should be referred for surgery. There's a high rate of return to play, especially with the docking technique. And although you can improve the person's performance, you can probably improve them close to what they were before they were injured in the first place, but you can't make them better than they were before injury. Thank you.
Thank you, Dr. Rizzio. That was really informative. Looking to see if you got any questions here. Anybody have any questions before we go on break? Yeah, I don't see anything in the chat, but we really appreciate your time this morning. Very good presentation. And for those of you in the audience, we're going to take a break here for about probably about 8 minutes. We'll return around 11:33. All right. We are back for the last segment of today's program. Thank you for sticking it out with us for the full day. We have our rehab segment now. Dustin Baldwin. Dustin is a doctorate of physical therapy and a certified strength and conditioning specialist. He's currently a member of the sports medicine rehabilitation team here at Cooperman Barnabas Medical Center. Spends a lot of his time at the JCC in West Orange, helping out a lot of our athletes. He is a youth athlete specialist. He also has much experience providing sideline medical care for athletes, both with AAU basketball and AVP professional volleyball, and is currently shadowing with the Rutgers Division I basketball team, which I'm sure is a lot of fun, Dustin. He's going to be presenting to us on return to play testing for the upper extremity. So Dustin, if you want to cue your slides up there for us.
We good?
Yeah, you did that like a pro. You are all set.
Comes with a lot of practice. All right, guys. So like Diana said, I'm going to be talking about the return to play testing and just all the factors that go into the decision-making process to return to play. Just trying to build off of all of the great lectures that all the MDs gave today, kind of more focused on the pathologies. Now, basically, I want to take this jump ahead, post-pathology, post-injury, we've gone through the rehab. How do we decide if they're ready to go back to sport? So we are going to start with the testing section of the return to play process, since I think that's where it all begins. So first, I want to start with what is return to play testing. So it's basically putting objective measures to your return to play decision, right? You are going to pick a certain physical measure, and you are going to put the athlete through that measure and see how they perform. And the reason that we do this is because we want to see if the athlete is going to be able to perform out in the field, and if it's going to be safe for them to be out on the field. If they do not have the range of motion, if they do not have the strength, if they do not have the stability to be able to perform the sport, then they are probably going to compensate. They are going to do different motions, and it's going to put them at an increased injury risk, increased re-injury risk. And ultimately as well, they're not going to be able to perform if they don't have the requisite strength, power development, things like that, which I think is very important. We spend so much time focused on re-injury, but we don't talk enough about performance, in my opinion. And I think all the coaches, all the athletes want, their people performing, and we really want to make sure that they're able to go back out there and perform at the best of their abilities. So if we're going to be setting up a return to play testing, one of the biggest things that I say is a battery of tests is very important. No one test is going to give a comprehensive look at the athlete. Strength is just going to look at strength. Range of motion is just going to look at range of motion, right? We need to look at everything all encompassing. So I think it's very important to select a battery of tests to adequately assess this athlete. If you are lucky enough to work in a setting where you have the athlete pre-injury, I strongly recommend baseline testing. To perform baseline test, you get their true pre-injury data. So when we are looking, is the athlete back to that pre-injury state, which is ultimately what we want to do when we're making the return to play decision. If we have those baseline tests, it's going to be a lot easier to make that decision. If you're like most of us and we don't have that ability, making sure you have clear benchmarks for the test is very important, right? If you think that the person needs to have 80% of the number, 90% of the number, they need to be able to complete a certain number of repetitions for the test. Whatever you decide is your benchmark for the test, you have to set that before, so you are not trying to backtrack and figure out, okay, was this sufficient enough? You need to have clear guidelines, and then you want to be very consistent in your application of these tests so you can be very reliable and make sure that you're getting the same data and you can track progress. So what we're going to look at next is the big three, and not the initial heat, the Heatles with Chris Bosh, LeBron James, and Dwayne Wade, or any of the subsequent LeBron James big threes that have come since then. We're going to talk about the big three for the upper extremity here. And I like this baseball analogy because I think it is very nice to see that you can kind of have first, second, third, and then you get home, which in the home plate here is performance and back to performing their sport. So I think range of motion is the first key, right? You need to make sure that you establish the appropriate range of motion post the injury. And that really shows that the joint or the muscle itself is kind of quote unquote quiet, right? It's kind of settled down, less inflammation, all of that. We're able to get back to its normal physiological motions. And then if you look at this baseball pitcher here, right, that's a lot of range of motion. If he doesn't have that, he's not going to be able to produce out on the field the way he wants. So if we went round in first, now we're hitting second, and that's when we're going to look at peak torque. And this is pretty important. I know, we were talking a little bit before about endurance being a big factor here, which I definitely agree with, especially in a lot of these overhead athletes, because a lot of them perform a lot of repetitions. But for me, it all starts with peak torque, and I'm going to get to that a little bit later. And then the closed kinetic chain upper extremity test is kind of like the final piece of the puzzle, really testing the stability of the upper body. And then if you can kind of pass all three, you can get back to that performance. We're going to talk about peak torque and the closed kinetic chain upper extremity test a lot more in a second. Range of motion, I'm not going to hit on too much because I think it's pretty straightforward. You want to get them back to their physiological range of motion, unless they had some sort of surgery like a capsular shift or something where we're kind of intentionally tightening them up a little bit. So you might be a little bit less, but you kind of want to look at the procedure itself to see what you're expecting to get them back to. Looking at peak torque, there are two ways you can kind of assess it, and really there's only one way because you can really only assess torque isokinetically. When you do an isometric test, you're testing more peak force, but either way, they are great measures and the most important initial measures. So on the left, you see isokinetically, which is the gold standard. You can do more throughout range of motion testing, and it's a great way to get that endurance factor for sure. But bare minimum, we want to have some form of peak force testing. So most people are not going to have access to the isokinetic. I'm lucky enough to have one, and it definitely helps me out a lot. But a lot of people could set up a proper isometric setup if they gave it the time. And I think that when I say a proper setup, I think that's very key, because there are a lot of ways this could go wrong with a joint that has so much mobility. It's like the shoulder, or just the upper extremity just in general. There's a lot of degrees of freedom. The trunk plays a large role into it. So I really wanted to put a good picture up here where you can see a proper testing protocol. You see the person laying down in supine. Their body is blocked by the table. The therapist is using their arm to help stabilize, their thigh to help stabilize. They're pushing the dynamometer into a stable object that will not budge. I see so many people using their hand or some other form of resistance, and really all that's giving you is how much you can resist them back, as opposed to really giving you the peak force measurement that you're really looking for. So I strongly urge anyone who is doing this, or anyone who is recommending someone go through this, that they have a very consistent, stable setup, that you're pushing into something that's not going to budge no matter how hard you push, especially in some of our bigger athletes. The importance of this is, everything begins here, right? If you do not have peak torque, then you are going to have, the rest of all your contractions are going to be low, right? And especially as you fatigue more, you're just going to get lower and lower and lower, and that's going to lead to higher risk of injury, and, also, like I talked about before, decreased performance. So I think, the first checkbox needs to be that peak torque. If you do not have peak torque, you're probably not going to have the endurance component. You're probably not going to have a lot of other things. Even if you were going to pass other tests, it's probably more due to compensations than it really is due to your actual physical abilities, because a lot of these people are great athletes. So they're going to compensate in any way that they can. So if you don't have this, you're probably dealing with a lot of compensations from there. If you do have this, that doesn't mean you have everything, right? There's still just because you have peak torque doesn't mean you have endurance, and that's where some other tests can kind of come into play here. But this I would consider to be the bare minimum that we should definitely be testing out. Just wanted to throw up some normative data here in case you don't have that baseline pre-injury data. For most muscle groups, I generally think that greater than or equal to 90% is usually a good standard. There are some studies out there that say if you're going to deal with IR of the shoulder, because they're such big muscle groups, you want greater than or equal to 95%. And then particularly in the shoulder, which is a little bit more well-studied, you see a external to internal ratio, and then a torque to body weight ratio, which also can be very helpful, because sometimes you'll go through this process where the right arm is injured, it's the dominant arm, they're stopped training their left side, and if we just use a bilateral comparison, the left arm is untrained, you might be comparing kind of a bad number to a bad number, and even though they're close to symmetry, they really might not be at the level they should be at. So I really use ER to IR ratios and body weight ratios whenever I can, because I think that they can be very valuable to let me know if they're really at their peak where they should be. Moving on to the closed kinetic chain upper extremity test. It's a very simple test. Can be administered pretty much anywhere where there's a floor. Basically, 2 lines, 36 inches apart. Athlete's going to put their hands on each line, and they're going to go back and forth, touching their hands, almost very similar to a shoulder tap exercise. You are going to be doing this for 15 seconds, and you're going to record the amount of touches in that 15 seconds. I put the normative data down here, which is 21 touches, but I will give a little bit of a caveat to that, because a lot of that norm was done in high-level Division I and professional American football players. So if you are dealing with someone at a lower level or in a different sport, those numbers might vary. There are a couple of different studies out there that have norms for the different sports, so I would strongly encourage you look into those before you just take this 21 as a hard, fast rule. But the 2 biggest studies that really looked at this used 21, so that's kind of where I at least begin to talk about it. So now we've got all this great data. We've done all the tests. We have our test results. So now it's time to make the decision. Can we return this athlete back? And I think that it is important to have the test results, but there are also a lot of other factors that come into play here. So the timing of the season, which I believe Dr. Rizzio was kind of getting into as well, right? Is it preseason? Are they getting ready to go back to the postseason? Are we in the off season? All of those are going to affect things because we might want to push someone a little bit more if they're getting ready to go into the postseason. If it's the off season and their numbers aren't kind of that great, okay, what's the rush? Let's slow down here. Let's make a good decision for in the best interest of the athlete. Where in their career are they at? Are they a senior in high school that has no plans to play in college? Are they a freshman? Are they, all of those things are going to come into play here when you're making that decision, because if they're at the end and they really can try to push through just to kind of make it over that hump and they're not going to put themselves at greater risk, maybe we can try to be a little bit more aggressive here. I think previous injury history is a big one as well, because if this has happened multiple times, I'm probably going to tend to be a little bit more conservative than if it was just a first-time acute injury. And then I think one of the big ones that gets overlooked is the position and play style, the sport as well, right? If someone is playing left tackle and they have a left shoulder injury, that's going to be a little bit more exposed. We're going to get into a case in a second that's going to discuss it a little bit more. But if they are an offensive lineman versus a cornerback versus a safety versus a volleyball player or a basketball player, all of those people are going to be doing different things. And even within the same position, you might have a point guard in basketball who is more of a defensive player versus someone who's a little bit more of a shooter that might need their arm. All of those things kind of have to come into play to really help make the decision. And then the last thing is it's really shared decision making. Everybody on this call, from the AT, the PTs, the MDs, the athletes themselves, coaches, if it's a youth athlete, parents, all are shareholders in this decision. So I think communication all along the board, making sure everyone is on the same page for what's the best interest of the athlete, is very vital. So I would definitely recommend using that shared decision-making model. If you've gone through and you've just decided that it's time to return the person to activity, I think one of the more important things is a graded return to activity. So this is kind of a framework. It's not going to work really well for rowers, like Dr. Kim was talking about, or the rock climbers, like Dr. Petrin was talking about, because they're not going to have these full team drills or contacts or things like that. Even baseball is going to be a little bit different, but there's a lot of different articles out there on, upping pitch counts and things like that. But this is kind of a general framework just to show, listen, we want to be graded here. Let's start with individuals. Let's progress to some non-contact teams. Maybe we're going to do some one-on-one, and then slowly work our way all the way. Now that you were able to get through full practice, time to go back to a game. Well, you're not just going to go back to your full minutes, right? We're going to have a minutes restriction on there. And then as we slowly up that to become a full participant. All right. So I think that this can be overlooked as well sometimes. You just perfect, you're cleared. We check that box. See you later. Go back out there and go play. I think really making sure that we are all on the same page as far as the plan of slowly reintroducing them back to activity, so that they don't, one, get a re-injury, but two, you see all the time different injuries because their body is just not used to that training level. We throw them right back into a full practice, and something else kind of ends up happening, and then they're resetting that clock. We don't want to do that, right? We want to get our athletes out there, keep them out there, and keep everybody happy and healthy. So we're going to go on to a few cases here. First case, 19-year-old male, redshirt sophomore, left tackle for a Division I football team. He had a traumatic left shoulder dislocation, resulted in a Bankart repair 6 months ago, and spring practice is about to begin. So his test results over there on the right side. So if you guys want to just take a few seconds here and think about what you might do in this situation. Let everyone kind of read for a minute. And then I'm just going to kind of talk through really what I would say, the benchmarks that we talked about before for those peak torque measurements, at least 90%, so ER is a little low, nothing crazy. And we talked about 95% maybe for IR. So again, a little low. And then the closed kinetic chain upper extremity test, 18 touches, again, a little low, nothing drastic. So if maybe we had some different contextual factors over here on the left, like we're going to talk about, maybe things would be different. But you're talking about a redshirt sophomore, so he's got plenty of eligibility left. We talked about before, he's a left tackle with a left shoulder injury. That defensive end coming off the edge here, that left shoulder is very exposed. You have to protect that, right? If he was a right tackle, we might be dealing with a whole different issue here because his left shoulder is going to be a lot more protected. He's not going to be extending out to hit a reach block very, as often, where you're risking a guy kind of running into that arm, potentially having a different dislocation. So maybe that's a conversation you have if we needed to. But I think that is definitely a big factor. The fact that it's spring practice, and it's just the beginning of spring practice, and his numbers are very close, I'm not inclined to rush this person back because there's still so much time left in the season. We want to make sure that he's fully ready to go when the season comes. I think we could probably start him somewhere on that spectrum, maybe in the individual drills, maybe in some full team non-contact drills right now because he's very close, but still focusing on strengthening him up, making sure that we get those numbers exactly where we want it to be before we really move on that spectrum. So I want you guys to compare this case to this next case, and you'll see right off the bat, when we look at the numbers are a little bit lower. But when we go back to the left and we really put context to those numbers, we have a 17-year-old female senior volleyball player. She'd been in and out of the lineup for the past couple of years due to shoulder pain. And then she ended up having a debridement in her shoulder after the MRI revealed a labral tear. And this happened about 3 months ago. Her senior season starts in 1 week. And I should also mention that she told me that she has no plans to play in college. So taking all that into account, again, the peak torque generation is definitely low. The closed kinetic chain upper extremity is definitely low. But again, we want to kind of put that into context. 21 touches, Division I or professional football players. This is a different sport, different sex. Everything about this is different. So I would expect those numbers to be a little bit lower, but still something that you want to consider, right? This person, though, when I really look at it as a whole, it was a debridement surgery, so not too much we're worried about having anything happen to. It's just kind of going through, cleaning it up, getting her back out there. So that's less risky in my opinion. She's a senior, no plans to play after this. She really just wants to go out there and play her senior year, right? So with these numbers, they're not drastically low. If they were in the 60s, the 70s, I might have a different approach to this. But because they're decent numbers, and she really is just trying to get back out there for her last year, what I'm going to do in this situation is I'm going to be, make sure obviously the MD is on board, make sure that her AT is on board. And then from there, we're going to educate the patient and her parents. We're going to say, hey, listen, there is a chance that she might be at a slightly increased risk of injury because of these lower numbers. It may be a little bit harder for her to hit the ball because she just doesn't have the strength and the ability to control those forces in her shoulder. But it's not that crazy high to where right off the bat, I'm saying you absolutely cannot send her back, right? And I think that that's a big key, so you give them that information, you let them make a little bit of the decision, and you come to that shared decision-making process. And so I think that's where the gray comes into this, right? I'd love everything to be black and white and just be the test results, but that's not the case. And I love everything to be like, oh, she's a senior, she just really wants to get back out there for her last season. But if her test results are not there and you really think that she is going to be at increased risk of doing something harmful to her shoulder long term, then I think you have to be able to make that decision. And it's probably one of the hardest parts of our jobs, telling that person that they can't go back out there. None of us like doing it, but it is important, and that's why we do want to go through and appropriately and adequately return to play test these athletes. Does anybody have any questions?
Thank you, Dustin. That was really great. Don't see any questions just yet, but very cool lecture. I liked, kind of your application with the case reviews and stuff. It got me thinking a little bit, so I think it got the audience thinking as well. Thanks for your time this morning. Very much appreciate it.
No problem. Thank you.
All right, next we have Marissa. So Marissa Bingler is going to bring us home here. Marissa, we'll give you presentation privileges there if you want to cue up your slides. So Marissa is going to be presenting today on behalf of JAG1 Physical Therapy on shoulder instability in the overhead athlete. She has her doctorate of physical therapy and has been with JAG1 for over 10 years. She's Senior Regional Clinical Director overseeing most of Northern New Jersey JAG1 PT offices and treats mostly out of the West Orange office. She treats a wide variety of athletes and enjoys providing education and tools to the sports community regarding injury prevention and performance. All right, Marissa, your slides look good to me, so I think we're ready to go. Marissa, you want to try saying something? Just want to see if I can hear you. Okay. Just give you a second here to see if you can cue up your mic.
Better? Can you hear me now?
Yes.
Okay, perfect.
Okay.
Very good. Hello, everyone. My name is Marissa. Diana, thank you for the intro. So basically today, I'm just going to be reviewing what it looks like from a physical therapy perspective in these overhead athletes. What do we see upon the initial intake, and what are we looking at through the entire treatment progression? These are some of my objectives, just to be able to differentiate the varying degrees of instability that is associated with shoulder impingement in the overhead athlete, understanding the instability complex and how it leads to secondary shoulder impingement, and the evidence-based rehab techniques that will assist in getting our athletes back on the field. So what are we most commonly seeing in these patients that are coming into our office with the complaints of shoulder pain due to their repetitive overhead athletic performance? Typically, we're seeing the male athlete around 24 years old, commonly involved in contact sports, and we are usually seeing some degree of anterior instability and or shoulder pain. I'm going to be mostly focusing on secondary impingement as it relates to the primary instability that is mostly associated with that repetitive labral microtrauma to the anterior aspect of the shoulder in the overhead athlete. And when we're looking at secondary impingement, what is it that we're looking at in terms of instability? There are three categories of instability that we're looking at when we're performing our assessment. We have functional instability, which is more the beginning stages of the instability associated with the repetitive overhead activity. You're going to typically see stiffness. The athlete's going to complain difficulty warming up, pain with overhead activity, positive impingement signs, positive apprehension alongside pain. You're going to also see then the progression from functional instability to unilateral instability, or in that microtrauma phase. So with this, you're going to see pain that will increase with the overhead activity to the point where they're going to complain that they're unable to complete their performance. Some of the positive tests that you'll see with that is an impingement sign, a positive apprehension with no pain. So at this point, they're starting to guard the movement based on the pain that they've had with their activity. They know that if they continue to go into that apprehensive position of external rotation, that they're going to get to a point of pain. So in order to protect their shoulder from that painful sensation, they then kind of guard when we're performing that test, and they don't get to that point of pain. And then if we relocate the joint, then that painful sensation typically improves. And that's when we're understanding that we're a little bit more advanced with the instability and the impingement pathology. And then you have your multi-directional instability, hypermobility, and this will be found mostly in both shoulder joints, as that individual is most likely just hypermobile in general. So referring to the instability complex that is now causing our overhead athlete to have shoulder impingement and pain, we're looking at our overhead athlete. Here is an example of a throwing athlete. With the repeated throwing movement, we're having repeated microtrauma, which is eventually causing excessive anterior subluxation, mostly due to rotator cuff fatigue, glenohumeral joint tightness and abnormal movement through the joint there. That's then causing some of that anterior subluxation and impingement on whether it be your rotator cuff tendon, the labrum, bicep tendon, the recurrent subluxation, then resulting in secondary impingement and a more lasting pathology and painful shoulder. This is just some more detail on what the instability complex looks like leading up to our shoulder impingement. So like I had mentioned, repetitive stress results in microtrauma to some of our stabilizing structures. We also see rotator cuff fatigue with excessive overhead motions, also resulting in repetitive subluxation and therefore secondary impingement. And then of course, in the overhead throwing athlete, when you're, say for example, in your late cocking phase of throwing, you have that hyperangulation, then resulting in that excessive anterior translation of your humeral head and further impingement of some of those structures. Also looking at the sensory motor control here, we have our sensory input as we're getting into our overhead position and what are our muscles and joints going to do in response to that? How are we going to have proper movement to prevent injury and how are our muscles going to control that movement? Looking at EMG studies and evaluating different muscle activation between both skilled athletes with instability and without instability, you'll see an imbalance in muscle function that increased activity of the biceps and the supraspinatus. You will see decreased activity of the internal rotators that will permit greater external rotation. And anterior serratus is also with decreased activity, which therefore results in an increased risk of that anterior subluxation and again, further impingement. So in my clinical evaluation, what is it that I'm looking for when I'm evaluating this overhead athlete that is complaining of a gradual worsening of anterior shoulder pain? So of course, the history of shoulder pain that is specific to the anterior structures in the shoulder, pain that progresses with activity. It could be associated with a particular phase of throwing or overhead activity, such as in swimmers. You'll commonly find that in swimmers, they will specify the stroke that actually results in the specific pain in the shoulder, which helps you then identify exactly which structures are underperforming or overperforming. If there is a progression of any type of rotator cuff lesion, that pain will then be more often. You'll find pain at night, you'll find pain at rest. And here is just a swimmer as an example. Pain in the anterior lateral aspect of the shoulder, both during and after workout. Sometimes there's snapping during specific phases of their stroke, and then you have your 4 phases of your swimmer shoulder. When we are performing our physical examination, of course, we're looking very closely at coordination and co-contraction of all the muscles that make up our shoulder girdle. So this is going to include scapulothoracic muscles, your rotator cuff, your pecs, all the structures surrounding the shoulder, just to make sure that we're having adequate movement to prevent any further impingement in the shoulder. In addition to that, you can put the patient in a more challenging position, such as a push-up. It then stresses some of those stabilizing structures, and it can reveal any abnormalities in some of those muscles' abilities to stabilize the scapula and the glenohumeral joint. Obviously, you will perform your basic strength testing, your active passive range of motion, and like I mentioned previously, your impingement signs and special tests, and more specifically, your apprehension test, followed by the relocation test. Okay, so now we're going to get into some of the evidence-based rehab. So this is kind of really the meats and potatoes of the presentation. So what is it that we're looking to focus on when we are approaching these athletes? What do we want our treatment programs to be based around? So like I had said previously, a big issue in the overhead athlete is the repetitive movement. And what the repetitive movement causes is fatigue. And then it causes almost, compensatory patterns and poor movement patterns that then carry over to future play. So we want to re-educate the whole shoulder girdle system, and starting with the rotator cuff. So we want to improve our neuromuscular coordination of the rotator cuff. And there's different ways to do that. One way is co-contraction through rhythmic stabilization techniques, which there are many rhythmic stabilization techniques. You can do weight bearing, non-weight bearing. You can add resistance. You can just get creative with it. Of course, strengthening, including your rotator cuff and your scapular muscles. So elevation in your scapular plane shows the highest subscapular activity. Of course, external rotation, horizontal abduction, and then your scapulothoracic joint, all the muscles surrounding your scapula there. So I have some examples here. Here is a rhythmic stabilization technique. My colleague, Mike Hogan, he's a physical therapist. He's holding a weighted medicine ball to challenge the muscles to support the shoulder girdle. By me providing some perturbations there, it's forcing the muscles to then co-contract and stabilize the shoulder joint, keeping that humeral head in place with the force being placed in various directions at the shoulder. And another co-contraction rhythmic stabilization technique. I have asked my colleague Mike to place some force through the physio ball on the wall and work on stabilizing the scapula flat on his back there while I stress the position by placing forces in various directions and at various speeds through the ball there, hoping that he then can engage his rotator cuff and his scapula muscles to stabilize the whole shoulder joint. Here are some rotator cuff strengthening techniques. You have bilateral external rotation against the TheraBand, incorporating elevation. So we're incorporating that posterior muscle activation while moving the shoulder joint through elevation in order to let the humeral head there clear the space and just kind of prevent some of that impingement. And here we're doing our horizontal abduction through elevation. I really love this technique. I love this exercise because it's a good reminder of getting the shoulder in a nice neutral position, activating some of that posterior cuff there and those scapular muscles to really have a nice plane of motion through the humerus and the humeral head for good clearance of our tendons there. Looking at mobility, of course, we want to make sure that we have great glenohumeral range of motion and shoulder joint mobility. Most commonly, you'll find posterior shoulder stiffness. It is the most common adaptation in our overhead athletes. Some of the stretches that can be performed to address this is our cross-body stretch and our sleeper stretch. It is proven that a 6-week daily sleeper stretch program is able to significantly increase the distance in order to allow for those overhead athletes to have better positioning once getting into the overhead position. And in conjunction with doing your internal rotation sleeper stretch, you can consider to incorporate muscle energy techniques. I do love doing that when I'm doing my manual treatment with my patients. Muscle energy techniques do show to have immediate responses and is a good setup for then sending the patient home with a nice HEP exercises just to reinforce that improved range of motion that we've gained. Strengthening for SLAP lesion consideration. So we're looking more at pathology of the anterior shoulder here. So what are we going to address in order to further prevent that humeral head from anteriorly gliding and impinging on some of those anterior structures there? So we really want to look at our scapula and our posterior structures. Here I have my colleague doing a lower trapezius activation exercise. I really like this one done in prone as it really proves to depress and retract that scapula and really engage your trapezius muscle. You can also do it in standing. However, I find that there's many compensations that then take place in standing. I prefer the prone position. So this exercise then just kind of reinforces that posterior stability through the scapula and the glenohumeral joint there. Again, looking at the scapulothoracic joint, we also want to consider what structures are limiting mobility of your scapula. What structures are creating poor positioning or poor movement. Most commonly, you're looking now at your pec minor, levator scap, even your rhomboid as well. So some techniques you'll consider with this is a pec minor release, whether that be done manually, the physical therapist performing that pec minor release, and we can even educate our athletes to do this on their own. I do suggest you try this yourself. You know, we all do a lot of desk work, a lot of computer work, and our pecs tend to get tight being in that position. Take a lacrosse ball, kind of place it against your pec minor, find yourself a wall that you can comfortably apply pressure through your pec minor. I guarantee that everybody will feel an immediate release of tension through the anterior shoulder there, opening up the shoulder and almost even releasing tension that you could feel in the posterior aspect of the shoulder as well, just as it allows improved positioning of your scapula and shoulder joint in general. Just to go dig a little bit deeper into scapular muscle control, looking at some of the earlier stages through the late phases of rehab. In the earlier stages, for most athletes, due to the poor movement patterns that they have fallen into, it's really more about educating, some verbal cueing, some manual cueing on how to properly orient and set their scapula. So, you know, with them performing some very basic exercises, just kind of giving them that feedback and guidance on where their scapula should be in relation to where their humerus is with that specific exercise. As we get further into more advanced phases of strengthening, you then can challenge it with resistance or movement. And in the later phases, we'll then kind of consider what is it the sport that they are returning to. Is it throwing? Is it volleyball? Is it swimming? And let's incorporate the treatment program to mimic some of those movements so those muscles can then carry over to that function. Some examples here. I have my colleague Mike doing what's called a serratus anterior push-up. So I'm kind of guiding him on drawing his upper thoracic region towards the ceiling, pressing through his scapula to engage those stabilizing structures in the upper back thoracic scapula region. And here we're doing a weight-bearing stability movement exercise. Truth be told, in looking at this video, I would probably cue him to lift his chest up a little bit more in order to engage some of those scapular stabilizing structures a little bit better. But either way, that's the gist of the exercise, is really to make sure that you have your scapula flat on your back while you're challenging the movement by lifting up one of your arms and just trying to maintain that position through the scapula. Here we're getting into eccentric control of some of those posterior structures in your shoulder, your rotator cuff and your trapezius there. So by tossing the ball, he is then controlling the momentum of the movement. We're going in a PNF pattern and really just focusing, again, that eccentric control. That way you have some carryover with your throwing athletes. The rotator cuff is then more able to stabilize the joint and really prevent that excessive anterior translation of your humeral head. And this one we consider more of a plyometric endurance type of activity. So he's kind of just dropping the ball gently out of his hand there and just catching it. It's repeated through the rotator cuff and some of those scapular muscles. So just kind of building up the plyometric capabilities there. and then getting a little more advanced through our rehab program as we're working towards return to play. Usually from the beginning, I'd like to consider the entire kinetic chain just in preparation, and it's a good educational point for the athlete. Just making sure that we, advance the exercises to consider balance, trunk stability, hip stability. Ultimately, most of the time, these muscles are extremely important to also consider in proper performance of our upper extremities as well. In looking at ground-based sports such as baseball, tennis, or cricket, we are looking from the ground up through the trunk, and we're looking at diagonal patterns for proper muscle control and stability. Some examples of that would be a unilateral stance while performing some of your upper extremity exercises. So here, by bearing weight through just one leg, you're then challenging the leg that he's bearing weight through. You're challenging spinal stabilizers, you're challenging thoracic stabilizers, and hip stabilizers as well. And in your non-ground based sports such as volleyball, you want to consider loading the shoulder in closed chain positions. So here we have Mike in a quadruped position doing a pressing force through the physio ball there, as my video did not load that great in this slide, but pressing force through the physio ball there, and I'm applying perturbations, forcing the shoulder to then co-contract and control movements while in that position overhead. So just to kind of piggyback off Dustin a little bit, now that I've gone through my entire assessment and my treatment program, and the patient or the athlete is feeling significantly better, pain levels improving, mobility is looking great, strength is looking great, what is it that we're looking at to determine whether or not the athlete is safe to return to sport? We're going to just reassess at this point. We're going to look at our range of motion. We're going to look at our movement. We're going to look at our mobility, strength. Some of the tests that Dustin had pointed out before is absolutely perfect and critical for a safe return to sport. I actually have this all listed here as well, which he already went through, so I'm not going to be repetitive here. But, very important to make sure that we're looking at our internal rotation and making sure that that loss that we originally saw has improved and it is comparable to the asymptomatic side. Looking at our rotator cuff strength from an isokinetic view, an isometric view, and an eccentric view. And then, of course, making sure that our pec minor tightness has improved to open up our shoulder joint and prevent that anterior position. Here are some of our return to sports assessments. I have them all listed. We pick and choose, which ones we're going to do based on the sport that they will be returning to. They're fun and, they're active. Good. It's a great assessment to include with your basic range of motion and strength testing to really determine whether or not the patient, the athlete, is safe to return to sport. And that is it for me. Any questions?
Hey, Marissa, thank you so much.
Of course.
All right, you really brought it home there. We appreciate that. You're a good cleanup hitter.
Thank you.
I'm just seeing if we got anything. I got a couple things in the chat here. Let's see if we got anything. Let's see. Oh, you know what we did get? We got some really great feedback on the program today is what we got. So I want to thank, all our panelists for joining us today. I think there was a lot of great information. I know it was a half day, but I think our presenters did a great job of putting in a lot of good content in a short period of time. And they pretty much all stuck to their 20-minute timeline here. So I really, really appreciate that. I want to thank everybody here for joining us today, and we will be having some grand rounds programs coming up probably the first quarter of the year, sometime around January or February, so please keep a lookout for that. And we'll make sure we keep you in the loop with any future CE or CME credit events. In addition, please, as a reminder from what I said this morning, just give us about 7 to 10 days to get you information on how to redeem your credits. I promise we will make sure that they get to you as promised. All right, so everybody please enjoy your weekend and this fall weather. Have a great day.